Good morning, everyone. For those of you that do not know me, my name is Ann Brazo. I'm the founder of MPN Advocacy and Education International. Prior to starting this organization 8 years ago, I was with the MPN Research Foundation for almost 9 years. I'm very proud to say that it has been the most enlightening and wonderful journey for me. And because of the current situation with the pandemic, we have gone from in-person seminars and conferences to online webinars, as you obviously can see. And so bear with us as we host this event. This is the 6th annual Women in MPN program. We've been all over the country in the past, and so this is unique, but we have fabulous speakers this morning, and I'm very, very happy that you're joining us. And so for some housekeeping, I want to make sure that everyone knows that your microphone is muted, and you can send me or send a question anytime during anyone's presentation, and I will see those and field those and ask those questions of the presenter. I may not get to all of them, but we'll do our best. You'll be able to post those on the right of your screen. You have a control panel, and you will see audio attendees and handouts. Under the handout section is a copy of the agenda if you'd like to view that and see who's speaking this morning. And if you're unable to see everyone, you'll be able to see that person. Also, this is going to be recorded, and we will have the recording on our website and sent out to all of you. Let's see, if you have any problems, please email Kathleen Michael, our Vice President, at kmichael@mpnadvocacy.com. So this morning, our first speaker, I want to get to that right away because we have so many coming this morning. And I'm really, really very excited that Dr. Gail Roboz is joining us. She has been at a couple of our events and is a wonderful speaker, a wonderful physician and researcher. And Gail is with Weill Cornell. She's professor of medicine and director of the clinical and translational leukemia program at Weill Cornell College of Cornell University and the New York Presbyterian Hospital. Her topic today is very timely and one that I know all of you will be interested in. She will discuss the pros and cons of telemedicine for MPN patients during this insane pandemic. Please welcome Dr. Roboz.
Thank you very much for the invitation. I'm just looking at all the pop-ups that are showing up on my screen here and trying to figure this out. So hopefully you can see both me and the slides here, and I'm going to try to figure this out. But Anne, I'm so honored for the invitation. I'm sad not to be with everyone in person because I think we were on a floating boat at one point somewhere, and I and my slides and everybody else was moving a bit, and that was kind of fun. But it's fun to be together. We can't at the moment, but these topics have to get discussed, and patients have to get treated, they have to get their care, new research has to be presented, and we have to kind of march on, even though we're not doing that in the way that we most enjoy. So I was excited actually that you threw me a curveball this time, and I'm discussing something that's a little bit out of my usual zone. So I am not a tech expert at all, as will be quite evident as I mess up my own slides here. But what I'm talking about today is telemedicine. And I think that, COVID didn't invent telemedicine, but it certainly put it to the forefront of everybody's mind and almost every doctor's practice. And I think that because we at Weill Cornell and New York Presbyterian were really, unfortunately, at the epicenter of the pandemic, I think that's why this topic is one that I feel able to discuss, not because I know anything about the technology, but because I do know what it's like to be thrust into a new world of telemedicine because of what was happening with COVID. So I want to take you back for a minute, and it's a PTSD zone for me, but to March 10th, 2020, So my daughter was still studying abroad in England. My parents in their 80s were visiting her. And I get this email from a friend and a colleague in Italy. Hi, Gail, so nice of you to write. The situation is very scary. The hospital is under siege. Here in Florence, the ICU are still able to receive more patients. Death rate is 5%. We are not allowed to move from home unless you cannot work from home, and of course, unless you are a doctor or nurse. Supermarkets, shopping for food is allowed, are open, but many shops are closing. Streets are empty. It looks like a horrible B movie. So my office is just a couple of doors away from Dr. Ellen Ritchie, who's going to be speaking to you shortly. And I went to my friend and we sat there wondering, what is this? This isn't CNN being alarmist, which they are every minute of every day. This is an email from a friend and a colleague, and this sounds so scary. And in addition to trying to get my family out of England, which I did do, by the way, and safely, we started trying to figure out what to do. I mean, a horrible B movie, nobody's on the streets, stores are closed. This is unimaginable. And I guess some movies show this, but I don't really watch those kinds of movies. So we needed to do some planning. And actually, we published this in the Cancer Journal for Clinicians. Our colleague, Manish Shah, decided that it was going to be really important for others to figure out what we were doing at Weill Cornell, because New York was getting hit so hard. If you look at the colored part of the slide, this is what we were trying to do, patient triage. Well, there wasn't much testing. We didn't really know who was positive, who was negative. So in the blue, all right, if you have no COVID symptoms, then and you were not urgent, then the treatment was deferred. But what did that even mean, and for how long, and what kind of treatment? If you had no COVID symptoms and you were urgent, then what happens? So you're not COVID, but you've got something else that's going on that's urgent, but we can't mix you with the red people who have COVID symptoms and who needed to be put somewhere. Is it in the emergency room? Is it in the clinic area? And then we had some patients who were actually COVID positive, so they had to go to yet a different zone. This was really hard. We didn't know what we were dealing with. Many people were very ill. The hospital was filling up quickly. What I can tell you is that all of a sudden we needed to have new plans. We needed to reduce the on-site clinical volume. We were creating beds everywhere. We felt like there was going to be a ventilator in every bathroom, and we were trying to open up our clinic space. We were trying to have capacity to move patients. We needed to consolidate our practices. All of a sudden, you can't have the whole leukemia team in one place, because what if there's an exposure or more than one, and then all of a sudden our whole leukemia team gets taken out. So we had to move things around physically. There were major adjustments. And then of course, as testing became more common and more feasible, there was screening, but where was the screening going to happen, and who was going to do that screening, and what was going to happen after screening? Could you get your chemotherapy? Could you not get your chemotherapy? The complexity of this was enormous. And what I want to highlight to your attention here is what I tried to put in red, that in February, we had done as a hematology oncology practice count them, 4 video visits. And there were 702 in March. That's video visits. That's just what was captured by the practice. That doesn't capture at all I'm pretty sure I hit 1 billion emails. Everybody who I've ever met, most people who I've never met, and their families wanted to know, what am I doing? What am I thinking? Is COVID gonna hit me? Is COVID gonna do this? Is COVID gonna do that? The emails were unbelievable. The phone calls were unbelievable. Is all of that called telemedicine? I'm not sure exactly, but every single device was ringing and beeping as people tried to figure out what on earth to do in this absolutely unprecedented time. So there were some immediate advantages that emerged. Okay, so first, what were we told to do? Stay home. I was on TV early in the pandemic saying social distancing. I even made the comment that everybody was focusing on the social with little cute elbow bumps, but we were focusing on the distant. We didn't know what was happening. We didn't know what the infectivity was going to be and what the death rate was going to be. We were trying to keep people home. We live in New York City. There's a subway system. There's a bus system. Everybody's always on top of each other in New York City, which is usually what we love about being here, but not in March of 2020. Avoid travel, stay off of public transportation, potential exposures in doctor's offices and emergency rooms. The emergency rooms were filling up. We wanted people to stay home. So all of a sudden on the devices, on telemedicine, we could look at them. We could do a little bit of triaging. We could try to keep people out of the office who didn't absolutely need to be there. What about the healthcare workers? You will all remember, because it was incredibly, incredibly publicized, and it's still really going on. Conserve personal protective equipment, or PPE. Nobody even knew what PPE was a few months ago, and now even the kids are using PPE and everybody seems to know it. There weren't enough masks. We had to preserve them. We also had to preserve healthcare workers because many healthcare workers were getting sick, and we needed to make sure that the teams were spread out, and also to open up more physical space to see patients, to do COVID screening, and to potentially open up more hospital beds, especially for those of us whose clinics are hospital-based practices. Some triage was allowed. Let me take a look at you. Are you coughing once and you're freaking out because COVID is on the news every minute and you just need somebody to tell you you're okay? We could do that actually on telemedicine. We were looking at patients and trying to say, you look okay. Don't worry, you coughed once yesterday. Don't panic and don't come to the emergency room. That was actually very, very helpful. And actually telemedicine was applicable for both the outpatients and inpatients. So all of a sudden, 14 million iPads were appearing everywhere, and we were trying not to go into rooms where patients were very ill unless we absolutely had to. Part of this was horrible, and patients felt very isolated in the hospital. But part of it was amazing because we were able to talk to them frequently on devices with good quality, able to learn a lot from how they were feeling, but without spending that much time in the room in the middle of a disease which we didn't understand very well. So what is all of this telemedicine? So I actually clipped this from my own webpage, not mine, but Weill Cornell's webpage. So let's just walk through this. It's really easy. There are only 4 steps. Schedule your visit. So call the phone number and schedule it. All right, that doesn't sound bad. Download the WCM app, available for Apple and Android. Okay, this is already pushing my tech buttons. So WCM, I don't know if I know what that is. Now I'm gonna have to look that up. By the way, if I'm even on this web page, that must mean I have a computer and know how to use it. So everybody who's on this webinar this morning is at an advantage from everybody who doesn't have a smartphone and has no idea how to even get here. Create an account. After scheduling, you will receive instructions on how to create an account. That always makes me suspicious. Whenever I'm on a website that wants an account, I usually leave. Whatever it is, I don't want it because it's going to ask me 4,000 questions. And now, start your video visit. Read our instructional guide. There's a link to that on how to access your visit, and then download Zoom. Okay, is this really easy? Is this really not easy? Can everybody do this? Can 90-year-olds do this? I'm not sure. So what are some obvious limitations that we started experiencing? So everybody's gonna laugh now. Can you hear me now? I actually don't know if any of you can hear me now. I'm hoping that Anne would be texting me, but it's not inconceivable that I would be talking to this screen for the next half an hour or so with absolutely no idea that nobody can hear me, except the dog, but I'm hoping she doesn't come into the room. Can you see me now? The video's on, the video's off, nobody knows how to turn it on, then it's moving, the camera shifts. It's not easy. We're not all tech savvy, and we don't all live or work in a studio where this is obvious. What if you just don't know how to do any of this? You don't have internet, Wi-Fi, smartphone, tablet, computer, email. You don't know what all of these things are. You have an email account that your daughter set up for you 7 years ago, but you've never used it. All of a sudden, there was an incredible advantage to be a little bit tech savvy and to have access to all of this stuff, and an incredible disadvantage if you were not one of those people, because you're being left out of all of this. And to be honest with you, in the height of the pandemic, try to call an emergency room, try to call an urgent help, forget it. You're not going to be, you won't have been able to talk to anybody. Okay, what about the rest of us? We may have 7 advanced degrees, but you still can't figure out how to log into your visit. It's hard sometimes, and not that many of us know how to troubleshoot that. If it isn't working, I don't know what the workaround is for that. I have no idea why my Zoom is upside down. I have no idea why the background just switched to Star Wars. This is actually difficult for people, and it's stressful because you feel like you have a few minutes with a doctor and you want to optimize it, and the clock is ticking and you can't log into your visit. Language translation. How many languages can everybody speak? We usually in the hospital, when we're seeing everybody, we get interpreter services on the phone. We can communicate with almost anybody in any language, but how do you do that on a televisit? It's very hard. And furthermore, the instructions for getting onto the televisit aren't necessarily available in 600 languages. Privacy. Okay, well, I haven't even told my family that I have an MPN. And now I'm in my house with all of them watching me on a televisit where I'm talking about something that I would never even talk about on a good day with my family around. Furthermore, is somebody posting this on YouTube? Is Alexa taping this? Is Putin getting a copy of my visit? The privacy issues are huge, and they're very scary for people because we really have no idea sometimes what's being recorded, what can somebody look at, what can somebody bring back to be, potentially a weapon in the future. But also just on a simple front, how do you do this? How do I save my visit? Am I supposed to be taking screenshots? Patients don't really understand what they're supposed to do in the middle of a televisit. Also, by the way, not everybody has a blood pressure cuff or an oxygen saturation meter at home. Now, judging from Amazon, if you went onto Amazon in March or April, you couldn't buy either one of those devices because there was a run on O2 sat meters, because for COVID, we knew that as saturations were dropping, that was one of the indicators that you needed to be seen. But people don't necessarily have this at home. Oh, and by the way, if I go like this with my finger, nobody's drawing labs on me. We're in an MPN conference today. We're going to talk about labs, but okay, where am I getting my labs done? If I'm leaving my house anyway and going to get labs done, why don't I just go to the doctor's office? And by the way, Doc, how much does this visit cost? That's the one that sent me over the edge, because I can confidently tell you, I have absolutely no idea. We didn't know in any case, is insurance covering it? Is it not covering it? Is it a copay? If somebody just calls me on the phone and asks me a question or sends me an email, it's March. I'm answering everything. I'm doing my best to try to communicate with everybody. But what if they just call, then they don't get a charge, and then they have a video visit and they do get a charge? We had no idea. The doctors were actually not very able to answer these questions. And even currently with the evolving insurance situation, we don't really know sometimes, is your visit covered or partially covered? Or if you're out of state, is it okay? One day it's okay, and the government is saying you can help anybody anywhere, which sounds great. The next day it's no, I can only help people in New Jersey, but not in Connecticut. I have no idea, and there's no way to follow that in real time. Now, we're in an MPN conference, so what specifically for this audience can telemedicine do and not do? So the MPNs, things like chronic myeloid leukemia, PV, ET, myelofibrosis, there are a whole bunch of other ones that are not specifically named here, but just to put in some perspective, some of the big ones for some of you who might be on this call, what are we supposed to do with these diseases using telemedicine? So you're safe in your house, the door is locked, but what about your disease? Well, signs and symptoms, actually, you can get pretty good at this using a telemedicine visit. And what are the important ones for patients and caregivers on this call today? Constitutional, what does that mean? The totality of you. Are you much more tired than usual? Yes, we're in the middle of a pandemic. Everybody says yes to that, but you know what I mean. Can you not make it up the stairs? Are you having weight gain or loss, night sweats, appetite? Are you short of breath? Maybe you have an MPN that's transfusion dependent and you need a transfusion. Are you much more short of breath than usual? Can I see as the doctor that every word that you're saying is separated by a breath? I can tell for a lot of patients if you look short of breath, and I can ask you about it. Pain, headaches, chest pain, back pain, abdominal pain. I'm talking for MPNs now. These can tell a lot of things. A headache might mean that your blood counts are really high or really low. It might not mean any of that, but it could. Chest pain and back pain, abdominal pain, these things all have potentially specific meaning for patients with myeloproliferative disorders. And that's something that we can actually get to in a televisit. And you might even be able to show me, if you're pretty good with your camera, well, where does it hurt? Does it hurt here? Does it hurt there? And depending on who's at home, you might actually be able to show me something. Lift up a shirt. Is there a huge spleen that wasn't there a few months ago? These are things that you can potentially show me. Hold on one second. There's something that just popped up on my screen that I have no idea what it is. Well, I don't know if you can see it or not. Okay, random things happen in the middle of webinars. GI complaints, diarrhea, constipation. Maybe there's something going on with your medications. We're going to review all of your medications. That's something that can be done on a televisit. Maybe you're taking something new because you're stressed out in the pandemic. That's something that we can review and figure out if it's affecting any of your other medications. Your skin, bruising, new things on your skin, new things that you might be able to show me with a flashlight and with a camera on your phone or on a tablet. Neurological changes, any changes in vision, numbness, tingling. We can learn a lot about what's going on with you, and we don't have to have a very excellent setup with fancy high-tech cameras. But I think one of the things to keep in mind here is also the frequency. So how often am I talking to you on this televisit, and what types of signs and symptoms do we need to monitor urgently versus not urgently? And we're going to talk about that a little bit through the webinar today. But again, there's routine visits, and I'll go over for each disease what is a routine visit, but then there's also the new visits. Am I short of breath and coughing because I just spent 2 days with my cousin who was just diagnosed with COVID? There are lots of acute things related to the pandemic that we may be able to monitor via televisit and save you perhaps from going in and getting checked out. And then there are the routine maintenance things that are absolutely essential to keep your underlying disease under control, or if it's not under control, get it treated. Because one of the things I'm going to emphasize over and over again is that during this whole thing in March, in April, okay, keep everybody home, keep them safe until we can figure things out. But now time is passing. We're 6 months into this. COVID is not done. We can't let patients with well-controlled diseases lose their edge, and we can't let patients with new problems go untreated. So let's talk about chronic myeloid leukemia. One of the absolutely most important parts of chronic myeloid leukemia is monitoring of how you're doing by PCR, by monitoring a blood test. If you're a CML patient in remission, we want to keep you that way. And it's probably fine if you're in remission and you skip a couple of months of monitoring while we're in the middle of a pandemic. But you don't want to skip it for a year. And we want to make sure, how do you get onto these European Leukemia Net 2020 recommendations? How do you stay within these guidelines and make sure that you are not sacrificing your disease control on whatever medication you're taking? Well, that could mean a couple of things. Right now, for example, in New York, COVID rates are, thank God, very, very, very low. There are many safety procedures in place. And I want my CML patients to get their labs done. And a lot of them say, you know what, we trust your lab. We want to see you. They're coming into the office. If that's not practical, though, there are many ways to go safely into commercial labs to get this type of testing done. Make sure you're on track and make sure that COVID doesn't derail your good disease control. What about toxicity? CML patients are often on medications, tyrosine kinase inhibitors, things like imatinib or dasatinib, nilotinib, bosutinib, ponatinib. That's a mouthful for any of you who don't have CML, but for those of you who do, you know that on those medications, you can't just take it forever and never have a look at what's going on. You might need an EKG. You may need a chest x-ray if you've had some pleural fluid on dasatinib. What about myelosuppression? Some of these drugs, especially if you're new on them, can actually drop blood counts. We want to take a look at that. Well, how's your liver doing? What's going on with your kidneys? Lipid control, things like nilotinib, we really want to keep an eye on your lipids. What about glucose? And then special monitoring for patients on therapy-free or treatment-free intervals. Well, how are you doing? Are you having any TKI withdrawal symptoms? You CML patients know what I'm talking about when I say that. Are you checking that BCR-ABL? If you're off therapy, you're supposed to be, for the first year, checking that every month. Okay, you skip a month in the height of the pandemic, but you're certainly not going to skip many months or a year because that CML could be going out of control. So we've got to have the conversation. Telemedicine is great for that, but we've got to get the labs too. What about polycythemia vera? So for PV patients, again, you can't easily stick your finger through the screen and get those labs done. For patients, many patients with PV, there needs to be routine laboratory monitoring for possible phlebotomy. Some patients know when they need a phlebotomy. They might get a headache. Their blood pressure, if they're measuring it at home, may go up. They may feel a ton more pruritus or itching than usual. But some people may not know, and you do need to follow. And if you have well-controlled PV that is getting periodic phlebotomies, we want to see those labs. And if you need a phlebotomy, we want to get you safely in to have one so that you're not putting yourself at risk. What about bleeding or clotting complications with PV or with any of the MPNs? If you're like me, you are sitting a lot more than you used to. That is not a good thing to be sitting all the time for anybody, but especially with MPNs where you might be at increased risk for clotting. Are you on Zoom 12 hours a day? Wiggle. Get up, move, walk around, and certainly if there's any swelling anywhere, especially on one side of the body and not the other, you definitely are going to want to talk to a doc about that. Essential thrombocytosis. So again, some of these patients know very well when their platelets are flying. They might have a headache, vision changes, floaters. There could be bleeding or bruising, but there is some amount of routine laboratory monitoring. Some patients with ET actually might only need labs twice a year. And if you're stable and doing that and you're not going in the middle of COVID, that makes a lot of sense. But I'm pleading with the audience, don't be so frightened of COVID that you're not treating something that's potentially new or important. And there are so many tragic articles about this in the medical literature and in the newspapers. Heart attacks are getting missed. Infections are getting missed. Things that we can treat and get better and fix are getting missed because people are afraid to get the medical care that they need. Get the medical care. COVID's not a great thing to get, but we know a lot more about it than we did, and you're going to hear about this. And it is not the case that if you walk outside and somebody passes you and sneezes, that you're definitely going to get COVID and die. You must get things that are important treated and looked at. Don't wait. Myelofibrosis patients. Well, it depends. There are myelofibrosis patients who have the diagnosis but don't have any form of treatment, and they may only be getting monitored 1 time or 2 times in a year. But there are other patients who are much more symptomatic with this disease and may require transfusions or maybe on the verge of having more accelerated disease. There might be spleen monitoring or a specific monitoring related to treatments. Some patients might be on ruxolitinib, on Hydrea. Again, skipping a month in March, skipping something that is a brief period of time, we all wanted to do that and we were helping you do that. We were calling patients and saying, stay home. But that was then. This is now. Get your new symptoms looked at, get new findings looked at, and get those labs looked at so that we make sure that everything that was going well is still going well. Other telemedicine considerations for you guys on the call. So don't avoid the MD office or the ER, but don't overuse it either. If it's possible for you to get something checked out first in a telemedicine visit, do it. But things that are acute and severe, don't wait to go through 20 minutes of trying to log on. If you would normally call an ambulance, call an ambulance. So what about access to expertise or second opinions without the expense and the hassle of travel? That sounds great. Sign me up. I definitely want that. I want to talk to 12 different experts across the country and not have to move. And I think that's actually a fantastic option, especially for rare diseases, things like MPNs, where the experts might be all over the place. They might be tough to get to, and maybe you could get a few different opinions. I have no idea when or if this is covered by insurance. And while always the doctors, I mean, we're a good group, we want to help, we really try to help everybody who calls in. For an actual formal visit, you may need to check with the office or check with your insurance to see if multiple opinions would be permitted, because in the same way as they may not allow it in person, they may not allow it in telemedicine. Also, just be careful though. What did I just say? There are doctors all over the place and I can talk to all of them. How many opinions is too many? You know, there's an old joke that ask 5 doctors, get 7 opinions. It is so true, and that doesn't necessarily help at all. Controversial things tend to get even more controversial if you have too many cooks in the kitchen. And I would say that just because telemedicine is an option currently, don't drive yourself crazy by feeling like you have to hear what every single doctor who will see you has to say. It's not necessarily an advantage. Also, I decided yesterday when I was finishing my slides that I wanted to coin a new term, which is tele-abuse of the doctor. So you have to think about that. It's not easy. Emails, texts, constant barrage of technology gives patients the sense that there is immediate and absolutely unfettered access. We're the good guys. Most of us, we're trying to help. We want you to have access. We want to talk to you. We want to answer your questions, but it is completely impossible to real-time answer emails. And I got to tell you, my emails are, oh, just one more question, and we're 15 questions in. It's hard to keep up, and I think the frustration is that now that everything feels instantaneous, some of those answers actually aren't so quick for us to write, and some of them are not good conversations at all on a device, on an email. Even in a telemedicine visit, it's sometimes sensitive to have certain conversations. So give us a little bit of a break too. We're trying. Don't barrage the technology. Let's try to use it so that it's maximally effective and that we don't get people so tired out that we're going to want to turn off our screens. Also, clinical trials. This time has been a revolution in clinical trials, because while at the beginning of the pandemic, we were so upset because everything had to shut down. We couldn't start new trials and we could barely keep the ones that we had open because all of the resources were devoted to COVID. What we realized was, first of all, we opened up pretty quickly. By the beginning of June, everything was open again. But all of a sudden, we were able to do things that we were never able to do before. Ship medications to patients, do consents via telemedicine, do telemonitoring visits for what would normally have been an in-person follow-up, explain clinical trials to patients who may never have been able to come in to hear about one. And actually this was phenomenal. And we are hoping, and I'm always looking for the silver lining, even in a pandemic, we're hoping that many of these positives about clinical trials are actually going to keep going and allow patients to have access, allow the opportunity to hear about trials that can be helpful to you. So the future of telemedicine, it's here to stay. All the bugs are here to stay, but the good stuff is here to stay too. I think that if you read some of the articles that are coming out now, it really feels like, I guess when we watched the Jetsons, it felt like that was so futuristic and would never happen. Well, actually what they're talking about is optimization of medical records so that you can completely integrate it with your personal technology and tools for interpretation so that messages will pop up and explain to you what the lab test means so that you don't have to make a call for every single abnormal value. Expanded technology for home monitoring is already happening. Heart rate, blood pressure, O2 sat, and EKGs, routine. This is being done at home. Glucose monitoring, even PT-PTTs, other finger sticks. This is happening and is going to expand. We might even be able to do a complete ultrasound head to toe before too long and give that information right through the computer so that your doc can look at it. We definitely want to have optimized use for rare diseases, for MPNs, and especially for clinical trials. And we want that expanded access for patients and populations in need who just can't even get on this webinar to hear any of this. We have to help them get the access that they so badly need. And those were the comments that I wanted to make.
Gail, we are going to switch to Dr. Michaelis, and we will post questions to you via email. And I have several for you. So we're going to move right along to Dr. Michaelis. And thank you so much, Gail. I'm sorry for this glitch. Dr. Laura Michaelis is with us. She is in the Medical College of Wisconsin, the Froedtert Hospital. Dr. Michaelis, several years ago, we had a conversation about all the calls I was getting from women who had very specific issues, and she partnered with us all those years ago, and we're just so happy that you're with us today, Laura. And she's going to talk about what we know and don't know about COVID-19, which is extremely timely. Again, Gail's presentation was fantastic for all of you. I took a million notes, and that is recorded, so you'll be able to see that. And please welcome Dr. Laura Michaelis, and we look forward to this conversation, Laura.
Thank you. So I thought it would be helpful to talk a little bit about what we do know and don't know about the coronavirus, the novel coronavirus, and myeloproliferative neoplasms. And one of the ways that I always start this is, what actual information do we have? Now, you all know that when we have clinical trials, our best sources of information, for example, are randomized control trials. And we don't have very many of those in coronavirus. Now we have, for example, some institutional studies. Those are studies that have been published from hospitals like Gail's, like Cornell, which saw a huge number of coronavirus cases and collated that information to give us a survey of what happens with lots of patients. We have surveys conducted either in the United States, in Europe, in China, for example, about what happened to patients. We have a very important source of data called registries. And registries are where organizations like the American Society of Hematologists or the American Society of Clinical Oncologists or the European Hematological Association, those have people from all over their region send in information, regimented, uniform information on cases that they've seen. Sometimes we have information in the form of what we see case reports or case series, and sometimes we have just biological expectations. So we know certain cancers have certain side effects, and we know coronavirus has certain side effects. So what can we expect with the combination of those? So none of those are really good, hard, randomized clinical trials like you might see in the use of ruxolitinib, for example. 300 patients on this arm, 300 patients on this arm. We treated one arm this way, and then we compared the results. And that's because this is a new thing. That's because it's been extremely hard to conduct randomized trials in this very fast-moving environment. So when I need information on how to manage a patient or what a patient is in danger of, I go to expert guidelines, including the American Society of Hematology, and then some expert panels that have gotten together and published, you should do this for patients that have heme malignancies, hematologic malignancies, or blood cancers, and coronavirus. So what is known? And make sure that I'm advancing my slides correctly here. Sorry about this, guys. So what is known? We know a little bit about the rates of infection, and we know a little bit about the severity of disease. And again, I'm thinking about a population of patients who have both coronavirus and who have myeloproliferative neoplasms, or because that's pretty rare, the information that we have on people with coronavirus and any kind of blood cancer. Now, this information comes from the American Society of Clinical Oncology, which collects data on all cancers: breast cancer, prostate cancer, pancreatic cancer. Of their collection, they have, as of a month ago, 203 blood cancer cases. And some of those fall under the characteristic of myeloid neoplasms, like MPNs, about 13%. And the point of this slide is now we're looking at making decisions or making guesses about what's going to happen with a very small number of patients, 13% of 203. But it also goes to show that all patients with blood cancers are vulnerable to this, and that we continue to collect data on it. What about the American Society of Hematology? Well, I took a look at their registry maybe a week ago when I was making up this slide. And the information on this slide is helpful. First off, it says this is the number of patients. This is the number of patients that had coronavirus and these particular diseases. And then it says this many recovered, this many died, and this many, the outcome is unknown. So while frightening, this also reflects that people with more chronic diseases, those that aren't as aggressive, have lower death rates than those with somewhat more aggressive diseases. Now, we have to take this data with a grain of salt because these are registry data. This means that only the patients that are known to their doctors to have both coronavirus and a malignancy are registered. And it is a known fact that often the most severe cases are registered. So this isn't a great way to pull up the death rate because we don't know the breadth of people that never present to their doctor or are diagnosed in the community and are never hospitalized, for example. So I don't want you to take away too much about the death rate from this, but I do just want you to see that overall, we are seeing people with MPNs, including ET, PV, and CML with these diseases, and we are trying to record how they do. Now, the other thing to keep in mind is one question was, would people with myeloproliferative neoplasms have a different constellation of symptoms than others? And this again looks at all patients with just heme malignancies, including myeloproliferative. And what you see is their presentations are much like everybody else's presentation. The great majority have fever, cough, shortness of breath, and fatigue, which are the hallmarks of folks with coronavirus. And what about the duration of the symptoms? Again, many people present with no symptoms at all, and that's not uncommon. Some people have a very short duration of symptoms, and then some people have symptoms that go past 25 to 30 days. And those people we know can have fatigue for longer periods of time. That's a category of patient that may need additional workup or sort of formal management criteria for these longer people with longer duration of symptoms. That being said, most people, just like you've read in the paper, recover by the 2-week mark or so. So what do we know about cancer in general and coronavirus? Well, there's Chinese data from 2 studies, and as you know, the Chinese published multiple papers on this early on, and they showed that cancer patients who were infected with coronavirus had higher rates of severe illness compared to other individuals. And I've just got an email to expand my slides, and I'm trying to know how to do that. Hope that's a little bit better. So Chinese data showed that patients with cancer had higher rates of severe illness. They tended to be older, and they also likely had a history of smoking. They showed that cancer in their patients was the highest risk factor for having severe events. and including needing to be intubated or in an ICU. And again, this doesn't surprise us because we do know that um, comorbidities like smoking, like impaired lung function, like obesity, and like cancer are always harbingers of more severe disease. So, what about the fatality rates of patients with cancer? And again, I want to emphasize that this is patients with all cancers, people with metastatic breast cancer, people with metastatic pancreatic or urothelial cancer. And what we see is that the fatality rate for infected cancer patients in China was between 5 and 28%, depending on the aggressiveness of the tumor, versus 2.3% overall. Now, in the US registry data, the fatality rate is 13% for patients with cancer, and that increases if you're older, if you're smoking, if you have at baseline what we call a poor performance status, meaning you're not out of bed very often, you have lots of other medical issues. There's one case report out of New York City that said there was a 37% case fatality rate in patients with blood cancers. Now, again, I want to emphasize that this means this is not necessarily the risk of death should a patient with MPNs catch this. These are aggressive, these tend to be the much more aggressive hematologic malignancies, people with aggressive acute leukemias, or, for example, aggressive lymphomas. We do know that the healthier you are, that when you get this, the more likely recovery is. But it does mean that people need to keep in mind that having coronavirus on top of cancer is a complicated undertaking. And we know that most people with blood cancers and coronavirus recover. Some people do not. And as I said, these tend to be those with more severe outcomes. However, hospitalization is more often required than, or is about equally required. And that may be because of the fact that um, patients with blood cancers are watched a little bit more carefully, and the coronavirus is taken very seriously in those patients. In terms of treatments that people get, and we're going to talk a little bit about this later. So coronavirus treatments include, for example, there is a large number of people who are treated with azithromycin, which has yet to show significant benefit. Convalescent plasma, again, this is under study, has recently been approved for compassionate use and is something that's growing in use. We've now, while at the beginning of the pandemic, and this shows that a lot of these patients that were recorded in the registry were early on, were treated with hydroxychloroquine. This is no longer being used regularly. These additional agents are being used still in both in a clinical trial and off clinical trial. So another question is, are our MPN patients specifically uniquely vulnerable to coronavirus? Well, we do know that older individuals with myelofibrosis may be uniquely vulnerable, and that's because they tend to be in the older age group. Anyone over the age of about 70 tend to have a higher risk for severe illness if they get coronavirus. And people above 80, the case fatality rate is as high as 15%. We also know that individuals with pulmonary hypertension can have more difficult time with coronavirus, and that tends to go along with myelofibrosis. In fact, some case series have shown that up to about 30% of patients with myelofibrosis have some pulmonary arterial hypertension. And we know that MPN patients have higher rates of congestive heart failure, peripheral vascular disease. Now, those individuals are at higher rates of having severe disease if they contract coronavirus, but that doesn't mean it's because of their MPN. It may be because of their other health issues. Now, finally, we should note that both essential thrombocythemia and polycythemia vera have coagulopathic risks at baseline, and COVID-19 carries with it high rates of clotting, including venous clotting, pulmonary embolism, arterial clotting, and that might be synergistic, meaning that might combine the risks for somebody with ET or PV. Now, interestingly, we also know that MPNs can cause some level of immunosuppression. For individuals on medicines like ruxolitinib or fedratinib, there has been an idea that there's a slightly higher rates, and I would say slightly, with bacterial or, for example, herpes zoster infections. And that's been proved out by looking at some of the other studies. Interestingly, though, immunosuppression with ruxolitinib or, for example, fedratinib, but mostly ruxolitinib, has been explored as maybe one reason why individuals with MPNs might not have as bad coronavirus infections. And again, we're talking about MPNs within the subset of all the hematologic malignancy cases. And so we'll talk about that in a little bit. And finally, there are some patients who have what we call overlap syndromes. And these include, for example, something called MPN, MPD, or CMML. In those patients, we know that there's an increased number of these cells called monocytes or macrophages, and this may make people a little bit more susceptible to some of the kind of immune flare that you see in coronavirus. The reason why, when you read about it in the news, people are good for a week or so, and then they have this kind of crash where their breathing gets worse. In that subset of patients, that number of COVID patients that have this immune response in their lungs, we hypothesize that some patients with a disease called CMML, one of the myeloproliferative neoplasms, might be a little bit more difficult to manage. So one question I've gotten from lots of my patients is ruxolitinib going to protect me from coronavirus? I know it's being tested for treatment, and can it protect me? Well, if we think about the biology of this, we know that ruxolitinib, for example, decreases the activity of a certain kind of T cell called a T regulatory cell. It decreases the activity of a dendritic cell, and it decreases the activity of these things called natural killer cells. There are currently 20 studies looking at whether or not ruxolitinib is beneficial in people with coronavirus, and 10 are currently actively taking patients. Most of the time, this medicine is being given as a single agent, although sometimes it's being combined with other treatments. Unfortunately, we do not have any answers yet. So nothing's been published that definitively says Jakafi or ruxolitinib is helpful for coronavirus. And what I would definitely urge you to do is, if you're on ruxolitinib, you should not stop it. If you're not on it, you should see if there's a clinical trial available should you or your loved one get coronavirus. So now the big question, how do we manage patients with myeloproliferative diseases and coronavirus? So there's some guidelines out there, and this is what I turn to. This is what I've helped write. And these are also some of the sources that you can go to for if you want to look yourself. So if you go to the American Society of Hematology, there's a very informative COVID webpage. This is open to whoever wants to look at it. And it has a section called Frequently Asked Questions. How do I manage my patient with essential thrombocythemia? How do I manage my patient who's just had a stem cell transplant? When is it safe for somebody to go back into the clinic? So these are groups of experts who've gotten together and weighed in with their best guesses and mostly data-driven ideas about how to manage things. Now, there's been similar publications that take these same sort of guidelines and put them into published form. And these are some of the sources for those. And those are the types of sources that we go to when we're trying to figure out what's the best thing to do for the patient who's coming to my office this afternoon, recently diagnosed with coronavirus, who's on ruxolitinib for their intermediate 2-grade myelofibrosis, for example. And I like to pull those up when I'm with the patient in the clinic, or when I'm doing something remotely, and show them exactly the guidelines that we're using. So this is what it looks like if you go there. Here is the source that you can use, and it just goes through some of the questions that I've tried to address here as well. So here's a summary of the recommendations. So for myeloproliferative neoplasm patients, we're talking about myelofibrosis, essential thrombocythemia, and polycythemia. If those people are not infected with coronavirus, there is no data that they should stop their hydrea or stop their anagrelide, their interferon, their JAK inhibitor. At this point, nothing that's currently being used for cytoreduction should be adjusted. And you can change the phlebotomy schedules, as Dr. Roboz talked about, if needed, although you don't want to avoid phlebotomy, knowing that keeping that hemoglobin under control is a best way to prevent downstream effects like arterial and venous thrombosis. There's no reason to adjust the Jakafi that you're taking. The immunosuppressive effects are there. And if you're not on Jakafi, you want to do a nice risk-benefit discussion with your doctor about whether or not you should start therapy. Now, what about patients who have MPNs and then present with infection? For right now, we are not recommending that you discontinue MPN therapy in the setting of coronavirus unless there are drug-drug interactions. I do always recommend looking at COVID-specific clinical trials. Being on ruxolitinib might prevent you from being on some studies, but not all. And fedratinib, there's no evidence right now that either fedratinib or ruxolitinib is uniquely better for myeloproliferative neoplasms. I've had one patient who was just starting on fedratinib, still had ruxolitinib at home, and I switched him to ruxolitinib. I've had others who I've kept on fedratinib in the setting of coronavirus. Now, what about blood thinners? As we know, one of the major causes of the problems that are associated with coronavirus is clotting. And if a patient is on oral anticoagulation, for example, warfarin, or maybe one of the oral versions of anticoagulation that we call DOAC, like a Pixaban or something like that. If a patient is on oral anticoagulation, we typically transition to low molecular weight heparin, and we use low molecular weight heparin and aspirin only if we don't think there's a high bleeding risk. It's important to remember also that COVID can provoke low platelets, severe thrombocytopenia, and we need to keep a close eye on that. Now, the last thing is that this just goes over, the MD Anderson has a group of recommendations which largely fall under the what I just talked about. So are doctors actually doing this? Well, I did find when I was researching this talk an interesting recent study that showed that most Italian doctors, and you remember that the coronavirus outbreak was terrible in Italy in the spring, most of them during that time followed those recommendations, and that most people um, in continue to treat ET and PV patients as they would have otherwise, even in the setting of coronavirus. Most people continue to use ruxolitinib according to the routine practice and prescribing guidelines. And most of the time, after a patient with coronavirus has been diagnosed, and this is according to ASH, no change is made. So again, what this tells us is that we don't have randomized data. We don't have great hard acting data, but we do have a lot of consensus recommendations of common sense expert advice on how to manage people with coronavirus and myeloproliferative neoplasms. It's important to remember that COVID is a blood disorder, meaning it really changes your bleeding and clotting risks, and that's something that doctors need to to keep in mind. Now, of course, patients are concerned about their risk for infections and severe illness, and you guys can go to the websites that I've shown and look those things up. They're not secret. But remember, Most of this information is about patients with a great variety of blood cancers, including much more aggressive cancers like acute myeloid leukemia. So I don't want those numbers to be too frightening. There is no evidence that continuing chronic that JAK inhibition in the absence of other reasons for it is needed. So I wouldn't start ruxolitinib unless you're going to do that for your underlying MPN anyway. And there are guidelines that you can look into. So that's my talk. I can't wait till we put 2020 in the rearview mirror and move on to our next year and what we can do together as a team. I want to thank you all for listening, and I'm happy to answer any questions.
Thank you so much, Laura. That was fantastic. And we do have a few questions for you.
Great.
One is, the patient is trying to stay safe and doing all the protocols that are required of her in her community, but feels like she's not getting enough exercise, that, kind of back to what Gail was talking about, and has become much more lethargic over the last several months.
Right.
And can tell that her symptoms are changing because of that. Any input on?
Yeah, so one of the things that all of us have lost, at least I've lost as well, is the ability to go to the gym. I'm still a little hesitant to have folks here in Wisconsin go to the gym. The community prevalence is a little too high for that. And because people are exhaling and sweating, I just don't think, in my practice, I recommend against that. So what can you do? The first thing is to remember that weightlifting is something that we can do with our own bodies. There's great yoga and core exercises available for free on YouTube. So one of the things I did is I set up my computer in my living room, and I do YouTube yoga all the time. And all you need is a mat or a towel, and it's possible. The second thing is to recognize that outdoor and core exercises, a lot of personal trainers or gyms have switched to having a number of their personal trainers or teachers available on Zoom. So there's a ton of Zoom exercise programs that people can do, and you can do them at all levels of intensity. All you need is a couple of cans of soup, a stool, some tennis shoes. You don't need weights, you don't need a home gym or anything like that. So alternative home-based options. The second thing is remember to walk. So the walking is like the most important exercise, and you don't have to walk outside. You can put your mask on and walk in a socially distanced way in a mall, for example, as long as you're sort of staying in a well-ventilated area. You can walk outside, you can walk in place. There's a guy in, I think it was England, who walked a marathon around his lawn during his COVID quarantine. So put on a podcast, put on some nice relaxing music, put on something positive. And the third thing I would say is that lethargy might be your disease. I would definitely check in with your doctor, and it might be depression. The anxiety of this entire experience cannot be underestimated. There's plenty of people who've moved from a low-grade depression to a higher-grade depression because of the environmental changes that we're all facing. So don't forget to assess your mental health as well. See what's helpful. Journaling, art, music, positive stuff, taking a break from social media and the news, the stuff that brings us back to, our human body of creativity, peace, quiet, meditation, those kind of things.
Okay, Dr. Michaelis, can you give this patient and all of us a clear answer about whether hydroxyurea does or does not reduce immunity?
So I can't give you a very good idea because it's very specific. One of the ways to know whether or not the hydroxyurea has reduced your immunity is to check the subset of white cells. In patients, some patients become neutropenic with hydroxyurea. Some patients become lymphopenic with hydroxyurea, and you can check those by checking your subset of cells. Overall, we do know that hydroxyurea, even when it keeps your cells normal, you have an increased risk of skin cancers. And we believe that's because it has some suppressive effects even when you can't see it, on something called dendritic cells and T regulatory cells. That does not mean that you're especially vulnerable to coronavirus, but it just means that your immune system might work a little bit differently when it's surveying your body for something that's altered, like some skin cells, for example. So it's a complex answer. I would say that there likely is a small amount of immune suppression, but it's not necessarily the kind that translates into higher viral risk.
Okay, and just to interject one thing, when we knew we were going to have to be home for a long period of time, I went online and found an extremely inexpensive treadmill, and it works. And when the weather's cruddy, it is another alternative just in case. I mean, it was very cheap, very, very cheap. The other thing is, you and Gail both talked about some different things that MPN patients can do during this pandemic, but are there any specific things? For example, yes, we know to wear a mask in public. Yes, we know to wash our hands and use sanitizer, and to social distance. Anything extra that you think our patients should be aware of when they're in the grocery store? I mean, just anything that you can think of.
Yeah, I wish. Really, we don't know. The things that I will tell you is I think that the more severe disease is likely related to the level of inoculation. Inoculation is the amount of contaminant from one person to another, and the inoculation is more likely with coughing, sneezing, breathing, talking, laughing, singing. And so I am all about your mask. I'm all about, sometimes, I mean, from a healthcare position, we wear two masks when we're seeing patients. I just double up, especially when I'm seeing a patient. If we see patients, we also wear goggles. Now, goggles are not recommended in general, but I wear them so I don't put my hands near my eyes or rub my eyes. I'm obsessive about hand washing, but I don't wash I personally don't wash the food or the box of soup that I get from the store. I go to grocery stores, I have to, I need food too. But and when I'm outside, walking, if I'm walking, I live in a suburb. When I'm walking, I don't wear a mask unless I'm within 6 feet of someone else, and then I put one on. That being said, if I'm walking alone, I don't consider it. But some people I walk with, other physicians, wear a mask even outside. And my sister and her family do. And I find that I think that's, you sort of check what the rules are. I think those kind of precautions are helpful. And places that do those precautions, they've seen less coronavirus.
Thank you so much. So just to Laura, thank you very, very much. This was so informative. It was recorded to our audience. All of this is being recorded and will be accessible to you in the very near future. We will have that available. And also the ASH COVID site is on our website, and I know Laura presented that. And we are here if you need us. And so we will proceed. Thank you so much, Laura.
And it's a pleasure. Thanks, everybody. Stay safe.
Yeah, and any other questions that come in, we'll send to Dr. Michaelis. So now it is my great pleasure to introduce our scientific advisor and our dear friend who has been just a pal to us for a long, long time, Dr. Ruben Mesa. As you know, he is he's now the director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson Cancer Center, and we hope he is safe and sound. He certainly looks like it. San Antonio had quite a kick with this virus, and so we're very, very happy to see you, and look forward to your presentation on clinical trial updates and ongoing management of MPN symptoms. Thank you so much, Dr. Mesa. Can't hear him.
There we go. Can you hear me now?
Yep.
Yes? Wonderful. Great, great. And are you able to see my slides there okay?
Yes.
Wonderful. Well, and thank you so much. And what an amazing day so far. Wonderful talks by Gail and Laura. Really very, very relevant information. And you know, key kind of during this period of tremendous uncertainty. You know, this is such an amazing event, and now being the sixth of these, you know, really congratulations to Anne for really pulling this together, you know, both focusing on issues that affect women with MPNs, as well as having a chance to celebrate the absolutely spectacular women investigators in MPNs that we have in this field. Indeed, particularly poignant today, I think, as we have the memorial services for Ruth Bader Ginsburg, who really has been an inspiration to all of us. And I know I probably share the sentiment of many on the call who are really grateful for all of her gracious leadership that she has given our country over the years. So pivoting from the great discussion that you've heard and circling back a bit to MPN therapies and new therapies in development. And there are a lot of exciting things that are evolving, even with the impact of the pandemic. The good news is that progress in MPNs continues to move forward, and new therapies are being developed, new clinical trials are moving forward, and these things are not being held up because of the impact of the pandemic. Here are my disclosures. I pretty much am involved with most of the drugs that are being developed. So some of you have heard me speak before, and I recognize well that as MPN patients, you have many facets to how the disease potentially affects you. And this is crucial as we think about how do we best treat diseases that are complex like MPNs, but affect people in a very wide range of ways. There's risk of blood clots. There's potential of low blood counts. There is, for some of you, enlargement of the spleen, although that's primarily in myelofibrosis, but not exclusively. There is the difficulty of symptoms with MPNs that, as we'll discuss, are linked to the biology of the disease. They're not in your head. These are genuine aspects that come from the features of the disease. MPNs were concerned about progression, and progression is frequently what takes these diseases down a much more problematic path. But obviously, all of this exists in you as an individual, and your level of fitness, your health, the other medications that you take, the other illnesses that you face, your age are all factors that do impact what the MPN means for you. So let's jump into some specific updates. First, in polycythemia vera. In polycythemia vera, our goals of therapy historically had been to primarily decrease the risk of blood clots and bleeding. And I think our group has had a role, as well as many others, in helping to define that the goals in PVERA should be a bit broader. They should also be about the disease being as invisible in your life as possible, meaning less symptoms, still protected against vascular events, and ideally not progressing, and ideally not having a lot of toxicity from therapy. That's kind of the ideal goal. With our options in terms of phlebotomy, aspirin, medicines to lower counts like hydrea or interferon, JAK inhibitors, all possible things for us to utilize. Now, the current guidelines in the United States for higher risk patients bring together one, monitoring for blood clots and bleeding. Two, if you have cardiovascular risk factors, let's treat those. Let's give you aspirin, let's control the hematocrit under 45, and either hydrea or interferon as frontline therapy, with a long discussion in terms of the pros and cons of each. But there are individuals that clearly can do well with either of these two medicines. There's a lot of strength to both of these medicines. Now, individuals who start on one of these, we then really monitor, well, are they really achieving that goal that I shared with you? Is the disease as invisible in their life as possible? Do they feel well on the medicine? Are we stopping blood clots and bleeding? Are the symptoms better? If not, then we think about, well, should we change the therapy in some way? Circle back to one of the therapies that hasn't been used, use ruxolitinib, which can be beneficial as second line in polycythemia vera, or even perhaps a clinical trial. Now, there was a very interesting study that was presented earlier this summer from our colleagues in Italy. So despite them having had a very severe time with COVID, they continue their wonderful research as well as reporting on that research. And they presented the interim results of a low PV trial, meaning individuals age 18 to 60 without prior thrombotic events, or with those that had been called, quote, in the past, low risk. Now, this could include people who had symptoms and other difficulties. And everybody started with a hematocrit of under 45. And they randomized them to phlebotomy and aspirin, which is kind of the current standard, versus also giving them the long-acting interferon that is now available in Europe, ropegylated interferon alpha 2B, with a goal of better control of the disease. What they identified is that they had better control of the disease in terms of keeping that hematocrit down with individuals receiving the pegylated interferon. And the reason for this, you can imagine, if you're on phlebotomies, is that your hematocrit is always going up and down. And with medication, it might be able to be more level, and there may be advantages in terms of better symptom control, less iron deficiency, and potentially less risk of disease progression. Indeed, when we look at the symptoms, again, it strongly suggests that it was better to be on the pegylated interferon versus phlebotomy alone. So this has not yet led to an approval, but is a very important study in that this challenges the current way we treat PV and suggests that we may be correct in considering interferon earlier in the course of PVERA. Now, were there side effects? For those of you that have taken interferon, you know that there can be side effects. It was relatively well tolerated in this trial, but as with all things, there is a trade-off. A little bit of more in the way of symptoms, although many patients with interferons will have symptoms more toward the beginning of the time that they receive the medicine, but they do tend to decrease over time. So this interim analysis is very interesting, and you'll hear more, but this may be challenging how early we consider interferon in these patients. Now, moving on to myelofibrosis. For myelofibrosis in 2020, we want an accurate diagnosis. We assess what is the risk to the patient and the disease burden they face. We develop our treatment plan. We consider whether or not we should be considering a bone marrow transplant. Is that now? Is that at some point in the future? Or is that really not an option in the cards? For the majority of individuals, they go on to the frontline medical therapy, which for many has been ruxolitinib, but now could include Froedtert for a subset of patients. If you've been on medical therapy and the disease is progressing, we consider, well, should we circle back to bone marrow transplant? Should we move on to an alternative medicine? Or if an individual has progressed to acute leukemia, we now have different medicines which may be beneficial or helpful in that setting. Now, people have asked, well, I have early myelofibrosis, should I be on therapy? This is a term that's been used a bit, but it's quite mixed. Meaning, what does early mean? Does it mean that you've just been diagnosed recently? Does it mean that you just have mild anemia, or that you have just symptoms, or just enlargement of the spleen? Or does it have some implications in terms of how the bone marrow looks? Myelofibrosis can be quite a varied disease in terms of how it affects individuals. So there's lots of efforts to try to best understand how the disease behaves. Individuals with earlier disease sometimes can benefit from therapy. And I do think we will likely evolve to a point where most, if not all, patients with myelofibrosis are on some form of therapy. Now, for almost 10 years, we've had one primary therapy approved, with now Froedtert having joined it just about a year ago. And that therapy was ruxolitinib. And people have asked me, well, Ruben, define what does it mean to fail ruxolitinib? And I share with them, well, if you only have one option, failing it is always depending on what would be the alternative. And if the alternative is being on Rux with a partial benefit versus not being on Rux, for most individuals, they were probably better off being on Rux than being on nothing. As we have more options and we have trials, we certainly look at the spectrum of what does Rux failure mean? Well, have you been on it long enough? Have you had enough of a dose? And if so, what is changing about the disease? Is it further growth in the spleen? Is it movement toward acute leukemia? Is it difficulty tolerating the medicines? These are important as we potentially have other options in terms of where other options may fit. Now, we do know that people that have come off of ruxolitinib, the risk with them in terms of the disease is very stark. In particular, if the disease has moved further towards acute leukemia. So it's a critical risk to individuals, which is why we have so many clinical trials for these patients and why we are so working so hard to develop better options. Now, some in the past have wondered, well, what if you gave a holiday to ruxolitinib? Meaning you took it, you've had some progression, you stop it for a period of time, and you restart. And indeed, in some trials, this has been beneficial. And I have talks with people in many different parts of the world, some of whom only have ruxolitinib as the only option. They don't really have the likelihood of being able to travel for a trial. They don't have any other drugs approved in their country. And for them, this sometimes can be beneficial. For US patients, you usually have more options available to you than just ruxolitinib holiday. Now, first, let's talk about the other JAK inhibitors. So I've mentioned before fedratinib, which we'll get into, which is now approved. It's from Bristol Myers Squibb, and it's called Inrebec. And there are two drugs that are in large phase 3 studies that might be an option for you in important studies. The first is momelotinib, which might help to improve anemia in myelofibrosis, as well as splenomegaly symptoms, and pacritinib, which can be used in individuals with a low platelet count. Now let's first talk about fedratinib. So fedratinib was approved or was studied in phase 3 clinical trials several years ago. And there was a small number of patients, under 1%, that had a neurologic side effect of confusion linked to vitamin B1 called Wernicke's encephalopathy. So the drug got put on the shelf for a while. But there was great interest in it because the phase 3 trials had shown that the drug was pretty effective. And the FDA has given them an approval with one giving all patients vitamin B1 that hopefully will decrease or stop that risk of that Wernicke's encephalopathy, as well as monitoring the vitamin levels in the blood and monitoring for this toxicity. And hopefully this largely helps to decrease that risk or block that risk altogether for patients. So the drug is now approved, although we monitor for that rare side effect. So we've done some new analysis on these studies that were completed. And one of them that Claire Harrison and I presented at ASH last year was in individuals with a platelet count of 50 to 100,000. And the reason for that is that normally patients in that range receive ruxolitinib, but at a dose less than the full dose. So we looked at this group that received full dose fedratinib, and were able to see that there was good response rates in terms of spleen and symptoms compared to placebo, suggesting the drug could be used safely and effectively in that group of patients. Next, we looked at the impact on both symptoms and quality of life, and saw that fedratinib, compared to the comparator arm of placebo, was very significantly effective in improving each individual's symptoms, and it usually improved those symptoms by even 1 month in, that's cycle 2, day 1, which is about 30 days in. We also saw that there was a meaningful improvement in terms of quality of life compared to placebo. Now, this is very key because quality of life also helps to factor in side effects, how well people feel, and gives you a better global sense of how well someone did with the medicine. Now, fedratinib is approved to be used either the frontline or second line setting. So another analysis that Dr. Harrison and I did was on the Jakarta-2 study. And here, now having had more years of information, we decided to look at the initial information which had been published and we tried to drill down more specifically on a strict definition of who had failed ruxolitinib. And amongst those individuals that had had a strict resistance or intolerance to ruxolitinib, we see that about a third of patients that have failed ruxolitinib benefit from fedratinib. So if you are one of those individuals, that again may be something that is worthwhile for you to discuss with your physician as one option that now can be prescribed as a second approved therapy for myelofibrosis. Now, I mentioned pacritinib before. Pacritinib can be used in individuals even with a platelet count below 50, which makes it a bit distinct from both ruxolitinib and fedratinib. And there have been studies, of which I and others on these webinar have been involved with, that have shown the safety and effectiveness of pacritinib, and is currently in a phase 3 study called Pacifica with individuals with a low platelet count, and strongly encourage you to consider that trial. Next, there's momelotinib, a phase 3 study that I and others helped to lead of momelotinib versus ruxolitinib that showed similar effectiveness against reducing the size of the spleen. At the time, perhaps a little less effectiveness in terms of the symptoms. Now that we've drilled down into this a little bit further, they actually are probably much closer in symptoms than we had first estimated, and that these drugs have very similar effectiveness in spleen and symptoms. The difference might be that momelotinib might be better in terms of the issue of anemia, because it helps to decrease an inflammatory marker in the blood called hepcidin that might be interfering with blood creation. So on this basis, there is a trial that Serge and I are leading that is momelotinib versus danazol as a phase 3 study. So I would heavily encourage people who potentially might benefit to consider that option as well. Now, your doctor has both the drugs that are available in clinical trials, but has other things up their sleeve that they sometimes can use. And that is part of the art and the science of treating myelofibrosis. Other drugs that might help to be added in to help with anemia, or to help if there's other complications that arise with the disease. Now, there are many exciting new drugs on the horizon, and they are working against the disease potentially in a variety of different ways. You could think that these are all pathways in kind of the control system for growing the MPN cells in the bone marrow, and they're all looking either alone or in combination with ruxolitinib, or potentially in combination with fedratinib or other JAK inhibitors that have an impact on the disease. So let me highlight just a couple of these. First, in patients with myelofibrosis, if they have anemia, if they have an inadequate level of erythropoietin in the blood, we may add danazol, we may add IMiDs, we may add prednisone. Another drug we may be adding soon is the drug luspatercept that is approved in MDS and hemoglobinopathy, so 2 other diseases, and it has shown beneficial impact in helping to improve anemia, either alone or in addition to ruxolitinib for people with MF. Next, there's the drug from Constellation Pharmaceuticals, the BET inhibitor, CPI-0610, that is helping against the biology of the disease in additional ways, in terms of differentiation of the cells in the bone marrow, as well as in inflammation, and potentially in individuals with ASXL1. This drug has caused quite a bit of interest because of benefit that has been seen in a variety of different situations. Individuals that have failed ruxolitinib and are off it, or in addition to ruxolitinib in people with a partial response, and showing benefit in terms of spleen and symptoms in each of these groups, as well as potentially as a benefit to adding it to ruxolitinib in newly diagnosed patients to see whether the response rate as well as the depth of the response is higher in that group. Side effects, again, include many of those things that we know for these therapies that can lower the platelets or the red cells, and there can be GI-related side effects. The next is another add-on study of the drug navitoclax that works against a system in the cells called apoptosis, which is how cells normally grow and then are kind of put to rest. In this trial, where the second drug was added on for people with a partial response, we see good responses in terms of spleen and symptoms by adding this drug in addition. There's a cousin of this drug currently approved for acute leukemia called venetoclax. Here showing symptomatic improvement. And here showing changes in both the white blood cells as well as stability in anemia and a bit of a decrease in the platelets, but then stabilization. Again, primarily watching the blood counts and GI side effects tend to be the main theme of side effects with these sorts of drugs. Final drug that I've been involved with both in ET and myelofibrosis, the LSD1 inhibitor IMG-7289. Christian Pettit, a great friend, presented this data at ASH, where the inhibition of LSD1, again, working against the cells in the bone marrow responsible for MF, helping to improve symptoms, fibrosis, and potentially splenomegaly. And potentially might be active against the spectrum of MPNs currently in trials at our center, both in ET and in MF, as well as in several centers nationally. When they showed before, and this data continues to be updated, showing good improvement in terms of spleen and symptoms in this therapy under development, with side effects can have some impact in terms of GI or some alterations in taste, and it clearly can lower the platelets, which is part of our goal with ET. So how might these things impact how we approach therapy? Well, first, if we think about myelofibrosis, our frontline treatment that doctors go and look at this now as the NCCN guidelines is ruxolitinib or fedratinib, in particular in those individuals with lower platelets. Likewise, for second-line therapy, you might think about fedratinib. The other new therapies might come into this group in terms of they receive rux or fedratinib. If they don't have a great response, do we add one of these other drugs in? If they have anemia, might we add in luspatercept or might we use momelotinib to begin with? If they have thrombocytopenia, might we start with pacritinib in this group of patients? Might we add the CPI 0610 to this group? Would it be for all patients? Would it be a subset? Finally, in individuals that progress to acute leukemia, there's a whole host of new drugs that are available that might have benefit for this group. So with that, I very much would like to thank Anne and the MPN advocacy for all of the fantastic work they do. Obviously, I am just one member of a much larger team that cares deeply about you, our MPN Quality of Life Study Group. This is just a partial showing of many of my friends and colleagues that share this mission to not only try to cure MPNs, but to try to improve your quality of life. And with that, I would gladly stop sharing my screen and take a couple questions.
Thank you so much, Ruben. I do have several questions for you, and let's start with, let's see. So for MPN patients, and maybe those at high risk, but maybe not, what happens when a viable vaccine is in the open market for COVID? And, what are your thoughts about how our patients should navigate through, getting a vaccine, maybe not the first one, but maybe the third one, available? Can you answer that or talk about that?
It's a good question, and I think when we're actually in that situation, Anne, I think you and I will sit perhaps with a couple others and try to tape an immediate video to be a resource for folks. My inclination, to be honest, is barring there being something really surprising about the vaccine, I will be recommending that all MPN patients receive the first vaccine. I think MPN patients are rarely so immunocompromised that receiving a vaccine, particularly in this setting, of a life-threatening viral illness that is universally in our communities, they probably most will be able to receive it safely. We don't know yet because we don't know which one will be approved. Is it a live vaccine? Is it not a live vaccine? And like all things in medicine, it's always a question of risk versus benefit. But it is rare for the MPN patient to be so immunocompromised that a vaccine in this setting really would be a non-starter. It might be different for a patient that is just recovering from a bone marrow transplant, is in the hospital with acute leukemia, but this is one where we want to divorce all of the politics from this aside. If this can help to protect you further, there's got to be a very strong medical reason we would have to see to tell people not to get it.
Okay. AFib is very common as we age. What are guidelines about anticoagulant treatment in MPN?
Overall, we think that anticoagulants for other conditions, largely should be given as normally recommended, but that your cardiologist and the hematologist should coordinate. So there are times clearly that MPN patients may have some additional risk of bleeding, or that they may have low platelet counts, and that can factor into weighing the decision as to which anticoagulant, which dose, and how that is monitored. So again, that's a prime example of where both should communicate, but for the large part, we don't want to undertreat other diseases that can be life-threatening. I have seen, unfortunately, many MPN patients who sometimes have had a negative consequence by another disease because they were too conservative, or their physicians automatically assumed that I can't give an anticoagulant to this patient, and then they have an adverse event.
Okay, two more questions. Excuse me, two more questions, and then we'll move on, but I will email you some of these other questions for your response.
Great.
Okay, so how is interferon B different from interferon A, as it is a question of effectiveness?
In terms of the effectiveness against MPNs, you could think that they're relatively equivalent. There's slight differences in the molecule, but what they're doing is relatively similar. The drug in question, ropegylated interferon alpha 2B, and pegylated interferon, or Pegasus, that many of you are familiar with, is pegylated interferon alpha 2A. So when the pegylation is something that allows it to be in the system longer, and with ropegylated interferon, people get it every 2 weeks versus every 1 week. There's other differences. You could think of a Coke and Pepsi type situation where they're both similar drugs, but there are some differences. There's at least some sense that ropegylated interferon people might feel a little better on it, but we don't really have any direct head-to-head data. Why it's relevant is that the makers of ropegylated interferon, Pharmacentia in Taiwan, who's trying to get it approved in the US, and their partners AOP in Europe, is that both of those companies are very eager to have this medicine be a resource for MPN patients. Where the makers of Pegasus, they have not been inhibiting it being used in MPN patients, but it really has not been a priority or trying to get it approved. So the main advantage to ropegylated interferon is that if it gets approved, it will be a lot easier for MPN patients to receive it. It may not be a better medicine, but there's no indication that it would not be as good.
Thank you. Last question, is there ever any research being done on ET patients who are asymptomatic to figure out why they are and why others suffer so much? And could that data be used for other symptoms, for others with symptoms?
That's an excellent question. We clearly try to understand the entire spectrum of MPNs because, why one person has a different experience than another, whether that's why does one person have a blood clot versus not? Why does one person have severe fatigue versus not? Why does one person progress versus not? That is something we are very eager to learn. We are currently working on an analysis, potentially with the help of the MPN Research Foundation, of serially banked samples at the MPN Research Consortium from our clinical trials to understand the correlation between symptoms, cytokines, disease features, and progression. And that, again, the person that doesn't have symptoms may never develop symptoms. So what is the difference? If we understand that, we'll have a better true sense of the origin of why symptoms occur and how to help them in people who are afflicted with difficult symptoms. Thank you.
Thank you so very much. It was great to see you, even though it's, via cam here. We really miss you. We miss all of you in person, that's for sure. But thank you so much, Dr. Mesa.
A pleasure. Thanks, Ann.
Good. So moving along, we're going to take a 5-minute break. Next up will be our yoga instructor, meditation instructor. We have a few minutes in between, so stand up, stretch, do a little walking around your space wherever you are. Natalie Giocondo spoke at our last event in Boston and took us through some meditation and yoga. And this particular piece that she's going to do today is about sleeplessness. And so I know many of our patients have an issue with night sweats and just not sleeping well, aches in the legs and so on. So please return and you will see that piece, and then we'll move on with our physician speakers. Thank you. So we're back, and we do have our yoga meditation specialist with us, Natalie Giocondo. For some of you that are returning from last year's Women in MPN program in Boston, she was wonderful. And so take a breather with her, if you would. Hi, Natalie. And she wants to help you with some sleeplessness issues. So let's take a deep breath.
Good morning. Thank you for letting me join you for a few minutes today. I'm going to lead you through a short guided meditation that's intended to give your mind a rest. This meditation is called Yoga Nidra, and it's inspired by my vinyasa practice, the studio that I train with. Yoga Nidra supports deep relaxation and promotes better sleep. So let's begin. If you have the space and it's comfortable, find a resting position lying on your back. Otherwise, take a moment now to make yourself 10% more comfortable and close your eyes. For the next 15 minutes, your only job is to rest and move your attention through the body with my guidance. I'll keep track of the time. Give yourself permission to surrender your thoughts for a few minutes, knowing that anything that is important can be addressed after this short break. All minds wander. When you catch your mind wandering, gently bring it back to focusing on the sensations in your body. Take a full breath in through the nose. Hold it. A full breath out through the nose. Full breath in. Hold. Breathe out and rest. Breathe in. Hold. Breathe out. Rest. This time when you breathe in, clench the mouth and jaw. Hold it. On your exhale, open the jaw. The lips can stay closed or slightly parted. Relax the jaw. Swallow to clear the throat. Inhale and draw the shoulders up to your ears. Hold there. Exhale, roll the shoulders back and down. Rest. Inhale, hold. Exhale, send the breath to relax the upper arms, elbows, forearms. Rest here. Inhale, hold. Exhale, roll the wrist and open and close the palms. Rest the hands and wrists comfortably where they fall. Inhale, feel the chest and belly expand. Hold it. Exhale, let the entire front body soften. Inhale, tighten the lower abdomen. Squeeze the buttocks, tighten the hips. Clench, tighten, hold. Exhale, relax the lower body. Let the tension in the hips go. Release the buttocks muscles. Inhale, engage and tighten the upper leg, the front of your thighs, the back of your thighs, your knees. Tighten and hold. Exhale, release all of the tension in your upper legs. Relax the thighs, release the knees. Inhale, flex the feet back towards the shins, activating your calf muscles. Hold here. Exhale, relax the feet and release the calves. Wiggle your feet from side to side. Clench your toes and open them again. Think of relaxing the legs from hips to toes. Let the feet rest. Observe the body completely relaxed. Find your natural breath. There is no right way to breathe. Drop out of the thinking mind and become the sensation in your body. Take a moment to feel the sensations in your body. Place your awareness in the mouth and jaw. Let go of thinking. Allow total awareness in the mouth, jaw, tongue, teeth, and throat. Relax the jaw. Gently part the lips. Peel the tongue from the roof of the mouth. Relax the front of your throat and the back of your neck. Give up thinking. Surrender. Release. Allow awareness to enter the right ear. Feel the sensation in the right ear. Now shift your focus to your left ear. Feel the left ear. Now the right ear. Shift the focus to the left ear. Now feel both ears together. Bring your attention to your cheeks, your nose, the flow of breath in and out of the nostrils. Focus all your attention on the nostrils. Now, sense your cheeks. Bring your mind to your right eye. Feel the sensation in the right eye. Now the left eye. Shifting the focus to the left eye and the right eye. Sense both eyes together. Release the muscles in your forehead. Relax the eyebrows, the sinuses, behind the eyes. Let go of the tiny muscles behind the ears. Relax the whole face. Surrender. Bring your awareness to your scalp, the back of your head, your face, your jaw, your neck. Soften. Let go. Sense the right shoulder. Bring all of your attention and awareness to your right shoulder. Now your left shoulder. Shifting the focus to the right forearm. Now your left forearm. The right elbow. The left elbow. Notice sensation in the right wrist. The left wrist. Focus on your right palm. Now your left palm. Feel the right fingers. Now your left fingers. Sense your whole right arm. Now your whole left arm. Feel both arms together. Release. Going deeper. Feel the right chest. The left chest. Bring your awareness to your right abdomen. Now your left abdomen. Sense the right buttock. Now your left. Sense the lower back and the upper back. Feel the entire back body, the entire front body. Soften and release. Going deeper, observe feelings of peace contentment, and well-being spreading over the body like a blanket. With each inhalation, feel expansiveness and space. With each exhalation, surrender and let go of tension. Let your breath be natural. On your inhale, find expansion. On your exhale, more letting go. Inhale, expand. Exhale, release. Let's pause here for just a few moments. Start to bring some awareness back into the toes and fingers. Stretch or wiggle your toes and fingers. Notice the sound in the room around you. When you're ready, you can open your eyes. I hope you enjoyed this quick version of Yoga Nidra and enjoy the rest of your conference.
Thank you, Natalie. That was great. Thank you so much. I know
so much.
Kathleen and I enjoyed it. Moving right along, we are so excited that Dr. Ellen Ritchie is joining us again. She has done quite a bit of work in cardiac health and MPNs. And I always like to have her with us because, of course, there are all kinds of issues with COVID and heart health and blood health. And Ellen has really brought a lot of attention to the vascular issues. And so please join us. And if you have questions, we already have several for her. She's going to talk about cardiac issues and MPNs. And so please enjoy and send me the questions. We'll put those together for her at the end. Welcome, Ellen.
Thank you. I'm still waking up after my really nice moment of meditation. I hope everyone else enjoyed that. My talk is really going to be focusing on arterial thrombosis and, a lot of focus really on heart attacks and strokes. So I'm going to start with a case history. This was actually mirrors one of my own patients. It was a 50-year-old woman with no past medical history, and she presented to the ER of a local hospital with chest pain while she was gardening. And her labs were suggestive that she was having a heart attack, and her CBC was abnormal with a hematocrit of 57, platelets of 540, and a white blood cell count of 14. She ended up having a cardiac catheterization with a stent placed and was placed on Plavix, which is an antiplatelet agent, for the duration. She was referred to a hematologist for her abnormal blood counts. The hematologist found that she was JAK2 positive and her erythropoietin level was low, and a bone marrow biopsy was done. But while waiting for the biopsy results, she developed a right upper and lower extremity weakness and went to the ER again. She was given Coumadin in addition to her Plavix, and her weakness resolved after an hour. She was diagnosed with a transient ischemic attack, or a TIA. When the patient's bone marrow results were available, she was found to have a hypercellular bone marrow with increased red cells and some atypical looking megakaryocytes, which are pre-platelets, that were clustered and somewhat abnormal looking. Her karyotype, or her chromosomes, in her bone marrow were normal, but she was JAK2 positive with a high allele burden of 70%. She was started on phlebotomy and hydroxyurea with eventual normalization of her blood counts, but she required 6 phlebotomies over the next year. 1 year after the start of hydroxyurea treatment, she developed skin cancers on her lower extremities and had Mohs surgery. Given that she had skin cancer, she was started on another therapy to control her blood counts and was started on Pegasus or pegylated interferon with good count control. She required 1 phlebotomy the year after starting Pegasus. And she had no further blood clots, and her blood counts have been within the normal range for the last 7 years. Her JAK2 allele burden has decreased, but is still present at 48%. She has worked hard to modify her cardiac risk factors. She had an elevated cholesterol and is now on a statin with an LDL below 100. She had hypertension that's now controlled with a beta blocker and amlodipine. So this is a rather dramatic case of a patient with new polycythemia vera with, at the time of diagnosis, really serious complications, including a heart attack and near stroke. And what causes patients with MPNs to be at higher risk of heart attack and stroke? Some of them are risk factors that you share with all other people, which is age. Age is a really important risk factor in determining whether or not you have a risk of cardiovascular disease, and that's certainly true in patients with MPNs. Is it the higher blood counts that are associated with bad outcome? Is it the cytokines and inflammation that's a part of this disease? Is it the JAK2 mutation, for example, in blood cells? Is it comorbid illness, the fact that this woman had high cholesterol and hypertension at the time this all happened? Is it poor lifestyle choices, sedentary, poor diets, smoking? And does gender play a role in this? What can be learned from some of the data in cardiovascular disease from MPN patients? Well, it's interesting to look at a Swedish study or a Scandinavian study that looked at patients who were blood donors and looking to see what risk factors were for these patients for arterial thrombosis. And they found that in these patients without an MPN diagnosis, elevated hemoglobin is a risk factor for arterial thrombosis. This was a large study, well over 1 million subjects, and they looked at the risk of patients with higher hemoglobins as opposed to normal hemoglobins. The risk of MI and ischemic stroke was higher in both men and women with an elevated hemoglobin. In men with a hemoglobin of 17.5 or greater, the hazard risk was 3.52 for an MI and 2.36 for ischemic stroke. So anything over 1 is a high risk. In women with a hemoglobin over 16, the hazard ratio for MI was 2.35. And for ischemic stroke was also very high, as the value is not on this slide. The risk of venous thrombosis is most common in men with a hemoglobin of 13 or less, which offsets some of this risk. Nevertheless, in this study, hemoglobin by itself was a risk factor for arterial thrombosis. And that's in normal patients who are not diagnosed with an MPN. Coronary artery disease is driven by dyslipidemia and inflammation. And this was actually proven in a clinical trial called the CANTOS trial, where they looked to see whether an antibody against a certain component of the immune system was effective in decreasing the risk of cardiovascular disease. And the results of this study showed that using an antibody against something called interleukin-1 beta led to a lower incident of recurrent cardiovascular events compared to placebo. And the inflammation in atherosclerosis really is manifested by the increased presence of immune cells and inflammatory mediators and atherosclerotic plaques and the arterial wall and lymphoid tissues in circulation. Several studies have shown that the pro-inflammatory condition in cardiovascular disease originates at an early stage of hematopoiesis in the stem cell progenitor cells, and that there's a direct link between high cholesterol and the hematopoietic stem cells, where hypercholesterolemia causes these stem cells to proliferate, leading to leukocytosis or high white count and atherosclerosis in animal models and humans. The risk of thrombosis in MPN patients is well documented in the Swedish Cancer Registry, where in Sweden, unlike the United States, everyone who has a medical issue really is able to be evaluated. And there are higher rates of both arterial and venous thrombosis across all age groups and across all MPN subtypes. Arterial thrombosis at 3 months, the hazard risk is 3, but after 1 year, that decreases to a hazard risk of 2, and at 3 years, a hazard risk of 1.5. For venous thrombosis, at 3 months, the hazard risk is 9.7, but at 1 year, it falls to 4.7, and at 3 years to 3.2. The highest rates of thrombosis are seen shortly after diagnosis before optimal clinical management. And it shows that clinical management of these diseases can actually decrease the risk of arterial and venous thrombosis. Risk factors for thrombosis in MPN patients that have been documented from the data are an age greater than 60 and a history of prior thrombosis. Patients who also have other cardiovascular risk factors besides their MPN are also at higher risk, particularly hypertension and smoking. Patients with a JAK2 mutation and a high JAK2 mutation allele burden are at higher risk. Patients with erythrocytosis and leukocytosis. And patients with CHIP mutations, that includes JAK2, are at higher risk of cardiovascular disease. And patients who have in their blood elevated inflammatory markers, such as a CRP or a plasma p-selectin, are also at higher risk. The traditional risk factors really in patients with MPNs that have been associated with a higher risk of cardiovascular disease is age and a history of thrombosis. Again, this was documented in the Swedish Cancer Registry study where patients over 60, the hazard ratio was much higher compared to those who were under 60. And those with a history of thrombosis, the hazard ratio was much higher than those who had no prior thrombosis. And combining both older age and a history of thrombosis, the hazard risk of patients for cardiovascular complications was 7 as compared to 1 in patients who did not have this combination of risks. The ECLAP study is a study that was looking at the efficacy and safety of low-dose aspirin in polycythemia vera patients. And in this study also, they showed that patients over the age of 65 had a higher risk of cardiovascular complication. And patients with history of thrombosis also had a higher risk. So controlling erythrocytosis and leukocytosis is important in decreasing thrombotic risk. In the CYTO-PV study, which is a cardiovascular events and the intensity of treatment for PV, that was a study looking at JAK2 positive patients who were randomized to either intensive treatment with the goal of keeping the hematocrit less than 45, or less intensive treatment with a goal to keep the hematocrit, somewhere between 45 and 50. And looking at that data, patients with a hematocrit less than 45 had a much lower rate of cardiovascular death and major thrombosis than those who had the higher hemoglobin or hematocrit levels. That's one reason why your doctor tries very hard to keep your hematocrit below 45 because of the data that are derived from the CYTO-PV study. And looking at the efficacy and safety of low-dose aspirin in PV patient studies, they found the risk of thrombosis was increased when the white blood cell count was over 15. And this was especially true for the risk of MI. So it's important that both erythrocytosis and leukocytosis be controlled optimally to control the risk of thrombosis in patients with myeloproliferative disease. The risk of thrombosis is higher in JAK2 mutated patients with MPNs. So JAK2 mutated ET and PV patients have a similar risk of thrombosis, which is twice as high as patients who have a CALR mutation with ET. PV patients with a JAK2 allele burden of 75% or more have a much higher rate of major cardiovascular events and thrombotic events. And primary myelofibrosis patients with CALR mutations have a lower risk of thrombosis than JAK2 mutated patients, where JAK2 mutated patients have a thrombotic risk that is 2 times higher. So it's important to realize that JAK2 mutations are really associated with a much higher risk of thrombosis, and CALR mutated patients have a lower risk of thrombosis. And this impacts the way your doctor may treat you with a JAK2 or CALR mutation. Clonal hematopoiesis actually increases the risk of atherosclerotic heart disease. So there was a New England Journal of Medicine paper by Jaswal that actually looked at all sorts of mutations that are common in patients with myeloproliferative and other myeloid diseases, and found that presence of one of these mutations actually is associated with the increased risk of developing not only a hematologic cancer, but coronary artery disease and death. They looked at a number of mutations and found that mutations in DMT3A, TET2, ASXL1, and JAK2 were each individually associated with coronary heart disease. TET2 and JAK2 mutations are often commonly seen in patients with myeloproliferative diseases. CHIP carriers with these mutations had increased coronary artery calcification, which is a marker of atherosclerotic burden. So somehow or other, it seems that these mutations are associated with the risk of atherosclerosis. In 2 retrospective case control cohorts for the evaluation of early onset MI, participants with CHIP mutations had a risk of MI that was 4 times greater as those patients who did not have these mutations. And CHIP patients with JAK2 mutations had a 12.1 time risk of coronary artery disease compared to those who had no mutations. And in this study, they looked at a number of mutations. The majority of patients had a DMT3A mutation, but there were also patients with JAK2 mutations. Most patients had only 1 mutation, but some people had 2. On the bottom part of this graph, they're looking at the types of mutations that occurred and what the relationship might be to the development of this poor outcome. Patients with myeloproliferative diseases may have a higher risk of thrombosis if they have certain markers in their blood that show that they're in an inflammatory state. So Petrexin-3 and CRP may influence the risk of thrombosis in patients. In a study looking at a number of PV and ET patients, they noticed that patients with homozygous JAK2 mutations had high levels of an inflammatory marker called Petrexin-3, and that patients could have a high CRP level, which is also a marker of inflammation, independent of mutational status. But high Petrexin-3 levels correlated with a higher risk of disease progression and death. And higher CRP levels in patients correlated with increased risk of death, disease progression, and major thrombosis. So in multivariate analysis of JAK2 homozygous patients with high CRP levels those was a significant predictor of disease progression, death, and thrombosis. The relationship of sex or gender to the development of cardiovascular disease is not really well known. There aren't any particularly good studies, but Alison Malterno actually did a study looking at females versus males with MPNs and found that females tended to develop an ET-PV phenotype and had better survival than men who had more progressive disease and worse survival. So it's interesting to think what the role gender might play actually in cardiovascular disease. And certainly we know in patients without MPNs that there have been studies looking at the differences in outcome between men and women with cardiovascular disease. And I think it would be important to look at this in patients with MPNs. We just don't have that study yet. What are the treatment options to reduce risk of cardiovascular complications in MPN patients? We've talked about it before in Dr. Mesa's slides, hydroxyurea, which is inexpensive, but has toxicities, including skin cancer risk and myelosuppression. Interferon, which is more expensive, but it controls myelosuppression and has anticlonal activity. The recent data looking at rogue PEG interferon is really compelling that we might need to treat patients with this drug earlier in the disease than we had originally thought. The side effects, though, can be significant for some patients, including mood changes and autoimmunity, which can cause problems in long-term tolerability. And some people feel that a weekly injection really decreases their quality of life, and it's easier for a patient to take a pill. So that's something that needs to be discussed with your physician when you're thinking about initial therapy. Ruxolitinib is a very expensive medicine and is really there for second-line therapy in patients who are not responding or are intolerant of hydroxyurea or interferon. It can reduce spleen size and alleviate symptoms, but it's very expensive and has an infection risk, which is not really present with the other agents. And the data for support of ruxolitinib is really strongest in polycythemia vera. And the data is not as strong, and there's less data for frontline use in ET. Anticoagulation and antiplatelet agents may reduce the risk of thrombosis in patients with MPN. Certainly in polycythemia vera patients, we know that low-dose aspirin is beneficial to prevent cardiovascular events, and this was found in the ECLAP study, which I discussed earlier. Coumadin is also commonly used in patients who are at high risk for thrombosis, and there was a reduction in the rate of thromboembolic recurrence in patients who had previous blood clots, in patients who were receiving warfarin without a significant increase in the risk of bleeding. DOACs, which are the new anticoagulants, Pixaban and others, we don't really have a lot of large data sets looking at the use of this anticoagulant in MPN patients, but we have some small studies, one 25-patient single institution study and a retrospective study of 53 patients that really suggest that the use of these anticoagulants would probably be non-inferior to warfarin, which is commonly used. But larger studies are needed to actually document that. There's a lot more research that really needs to be done looking at the risk of cardiovascular disease in patients with myeloproliferative diseases. We need more information about the early use of interferon. It appears that that might be beneficial in patients with PV and ET and may decrease the risk of cardiovascular complications and thrombosis. The study of new agents in the development for MF and their efficacy in reducing the risk of cardiovascular events will be important, and their translation later on to PV and ET may be a further way to decrease cardiovascular risk in patients. We need more information about how CHIP mutations actually lead to atherosclerotic heart disease and the increased risk of cardiovascular events. In looking at this research, could we find new drug targets to decrease cardiovascular risk and early death in patients with CHIP mutations? We need more specific research on the relationship between cholesterol metabolism and inflammatory pathways in MPN patients to find new targets for treatment to reduce the risk of thrombosis and potentially reduce the risk of MI and ischemic stroke in patients who don't have these diseases. Efficacy of the new anticoagulants to reduce the risk of thrombosis in MPN patients, we need larger prospective studies to actually verify that it's non-inferior to warfarin in the MPN patient population. And it's important for women to realize that cardiovascular disease is the leading cause of death of women in the United States, and it's responsible for 1 in every 5 of female deaths. An outcome can be worse in female patients given decreased recognition of symptoms, that the symptoms that women present with a heart attack or stroke may be somewhat different than the way men present. And these symptoms can be overlooked, and sometimes less aggressive treatments can be given to women, which affects the outcome. And the specific research needs to be done looking at women with MPNs and the outcomes of cardiovascular complications. Do women have a better outcome than men with myeloproliferative diseases? And how can we better prevent these sorts of complications in all patients with MPNs. What can you personally do to decrease your risk of cardiovascular disease? It's important to reduce your cardiac risk factors, to eat a heart healthy diet and maintain a normal weight, to control your cholesterol. If your doctor says that you need a statin to control your cholesterol, you should probably do it. Exercise is very important, and in this time of COVID, certainly more challenging. But exercise is very important to maintaining your cardiovascular health and to maintaining a normal weight. For MPN patients, take your medication as directed by your physician, or a phlebotomy, whatever is needed to keep your blood counts under control and decrease your risk of arterial thrombosis. And if your physician suggests that you need a low dose aspirin, if you have PV, certainly, or ET, if it's recommended by your physician, you should take the low dose aspirin. It's an easy way to reduce your risk of cardiovascular complication. So that completes my slides, and I'm happy to take any questions.
Thank you so much, Ellen. We have a lot of questions for you, actually. First one, I know we've discussed at other events, and that is a person with an MPN who is at higher risk of coronary artery disease and so on. What about surgeries for these patients? What would you recommend?
So I would, if there is a surgery which needs to be done and is emergent, you'll need to have that surgery. But at the time of surgery, everything should be done to try and control all of your risk factors for cardiovascular disease. Sometimes new drugs are introduced at the time of surgery, like beta blockers, to help reduce your risk of cardiovascular complication. And certainly your hematologist is going to want to make sure that your blood counts are optimized before going into surgery, so that you're not going into surgery with an elevated hematocrit or a super elevated white count or platelet count, so that you're going into surgery, with all of your risk factors controlled to the best of the ability of your physicians. For elective surgery, you don't want to go have elective surgery unless all of your risk factors are well controlled. So let's say you're dying to have a knee replacement. You don't want to go forward and have that knee replacement until your blood counts are well controlled, that your cardiologist has determined that all of your risk factors are appropriately covered at the time of surgery to reduce your risk of cardiovascular complication.
And we also, and I know you would as well, recommend that all the parties, all the physicians involved with that patient should be communicating during this time. And, so the medications are known, the hematologist is aware.
And there should always be one way to determine, I think, whether you have a good physician taking care of you, is how willing they are to communicate with all the other physicians who are part of your care team. That's particularly true in the time of crisis, or an emergent surgery, or even in elective surgery, to make sure that everyone is on the same page.
Right. You mentioned statins for high cholesterol. What if a person is allergic or has all the side effects from the statins? What are the alternatives for that patient?
You'll need to talk to your cardiologist, who will really need to look at your lipid profile and determine what aspects of that are really poorly controlled. There are other options, such as niacin, which can be used to control cholesterol. But in a patient who is not able to take statins, that's one reason to really aggressively do other things to lower your cholesterol. So that would be, a really vigorous exercise program and a really careful diet, where you really are following an American Heart Association, low cholesterol diet, and eating a very fat-free diet. So doing everything that you possibly can. There are new agents which have been developed to control cholesterol. Some of them are extremely expensive. But your doctor will be able to determine with you, your cardiologist, what the best medications might be for you if statins are not available.
Okay, I have some more questions for you. Please explain CHIP mutations.
So CHIP mutations are mutations that can be found in older patients without even any symptoms of a myeloid disease or a cardiovascular disease. So if I went out on 2nd Avenue and chose to corral everybody over 65 and to do a blood test on them, I would find some people have mutations that are commonly associated with myeloid diseases, like in myeloproliferative diseases, myelodysplastic syndrome, or even acute leukemia. Patients are walking around with these mutations, with one of these mutations, which is really a sign of aging. Sometimes patients have one of these mutations with something that's going on in their blood, which is really not very exciting, like a mild anemia or a mild low platelet count. Not so much that it's really causing any symptoms in the patient, but these are patients who have mutations that may predispose them to the development of a myeloid disease later on, but are asymptomatic at the moment. But the thing that we're finding is that potentially patients that have these mutations who are asymptomatic, who are walking around, who are over 60, they may have a higher risk of cardiovascular disease by having some of those mutations. So I think in the future, when a regular physician, a primary care physician, is evaluating your risk of cardiovascular disease, they're going to start looking for these mutations in older patients as one of the risk factors for the development of cardiovascular disease, just like they look for your cholesterol and your blood, your weight and your blood pressure. So JAK2 mutations that are found, randomly in patients that might not have any symptoms of an MPN and are undiagnosed may lead them to have a higher risk of cardiovascular disease. But we don't know really the mechanism by which that happens.
I have 2 more questions for you. One is are there any insights into overlap of MPNs and other inflammatory diseases, for example, RA, and the various meds that are taken for both? Specialists seem only concerned about their own expertise, but little information about dealing with the risks of both.
So, certainly myeloproliferative disease are an inflammatory disease. And we're actually doing a study at Cornell looking at the relationship of Crohn's disease, which is another inflammatory disease, and its relationship to patients who have MPNs. We have a lot of patients who happen to have these 2 diseases in common. When you have an inflammatory environment, you may be at risk for other inflammatory related diseases. Rheumatoid arthritis is one of those diseases which is kind of in a black box. I mean, there's no real cure to rheumatoid arthritis, just as there's no real cure to myeloproliferative diseases. And we know that both of those diseases have an inflammatory background. Many different drugs are used to try and treat rheumatoid arthritis, and it's kind of a trial and error type of treatment program. In MPNs, our goal is really to decrease the risk of thrombosis, most importantly, and we have drugs which definitely we can use to do that. But we don't really use drugs regularly that hydroxyurea, for example, will not significantly change your inflammatory environment. Ruxolitinib may, interferon may, but their ability to sort of cross over and treat other inflammatory conditions is not clear.
Given that women die of heart disease in this country at a pretty high rate, should an MPN patient see a cardiologist regularly as part of their specialists in their group?
I think that it's important to have a really good internal medicine doctor. That's a really, really important aspect of taking good care of yourself when you have an MPN. your internal medicine doctor is going to look at your cardiac risk factors very carefully. And if they see something which they feel would be best managed by a cardiologist, then you should follow their advice and go forward and do it. But a good internal medicine doctor should be, doing EKGs and checking your cholesterol and checking your blood pressure and checking other cardiac risk factors, and should be able to manage your disease. But it's very important you find an internist who is interested in aggressive management and that is willing to seek expertise if they feel they need it.
Okay. And we're getting a lot of questions about rashes and open sores and so on, Ellen. And do you mind speaking to that for a moment? And then one last question would be for pregnant women who sometimes gain a lot of weight during their pregnancy. Are their risk factors elevated during that time for cardiac episodes?
I'll speak to the pregnancy one to start with. If you have an MPN and you're pregnant, you're at a much higher risk of early miscarriage, second trimester, and of thrombotic complications during pregnancy. It's really important if your doctor feels that you need to be on appropriate medication to control your blood counts. And during pregnancy, it used to be felt that it didn't matter. You could gain sort of as much weight as you wanted during pregnancy and it wouldn't make a difference. But that's known now that that's not really true. So when you're pregnant, just like when you're not pregnant, you need to try and eat a heart-healthy diet and to exercise to prevent yourself from gaining too much weight during pregnancy. Breastfeeding after pregnancy will also help you lose some of the weight that you gain during pregnancy. So these are all important issues, and you need a high-risk OB to be following you if you have an MPN and you're pregnant, who will be in contact with your hematologist.
One more question. I'm sorry, go ahead.
To answer the other question, hydroxyurea, can be associated with the development of ulcers and of skin cancers. And ulcerations, when they occur in patients who have hydroxyurea or are on hydroxyurea, it can be nearly impossible for those ulcers to heal as long as you are taking hydroxyurea. And the only real way to enhance healing is to take you off hydroxyurea and to have a wound care specialist actually manage those wounds and allow them to close. So if you develop ulcerations in your skin while you're on hydroxyurea, that is a real indication that you need to stop the drug and need to go on to something else to control your blood counts. I think that Dr. Michaelis actually discussed that your immune system, may react in such a way when you're on hydroxyurea that you have less surveillance of your skin cells and you have a higher risk of the development of skin cancers. And if you're developing a lot of skin cancers on hydroxyurea, that's also an absolute indication that you should go off this drug and you should be on something else to control your blood counts. And that you have a dermatologist who appropriately is managing your squamous cell or basal cell carcinomas. And that you always be mindful to decrease your risk of developing those sorts of cancers by minimizing your sun exposure.
Okay, well, thank you so very much. This was so informative. It always is.
Always
And
delightful to be here and to be a part of this.
we hope next year we'll be in person. That's our hope. We'll see what happens. We'll stay safe until then, however, and you stay safe, Dr. Ritchie. So moving right along, we have with us Dr. Catriona Jamieson. I'm so excited that she is here as well. We saw each other just before our pandemic proliferated throughout the states and have been on lockdown since then or not able to travel. Dr. Jamieson is professor of medicine in the Division of Hematology Oncology at UC San Diego. I have visited her there and in the past. She cares deeply about all of you, and she has done extensive stem cell research and will be speaking to us today, giving updates on stem cell research and MPNs and looking into the future. What should we expect in the future? So please welcome Dr. Catriona Jamieson.
Thank you so much, Anne. Can you hear me?
I can.
Oh, great. Okay, well, this is such a pleasure. You know, I wish that we could see each other in person. It's really always great to see really good friends and help our MPN community through the MPN Advocacy Group and MPN Research Foundation. I think as we look forward to the future, you know, this is the face of a patient that is known to a lot of us. Sandra is an advocate for all patients with MPNs. She's very hopeful for the future and has done well with her recent therapy. But I really wanted to focus on MPNs and stem cell biology. And what you see here is that myeloproliferative neoplasms actually derive from what's called a hematopoietic stem cell. We discovered back in 2006 that the JAK2 mutation actually occurs at the level of a hematopoietic stem cell, which basically lasts our lifespan. And so the reason that's so important is we have to be able to target that cell to be able to get rid of the JAK2 mutation. Others showed subsequently that the calreticulin mutation is also at the level of a stem cell, and the thrombopoietin receptor MPL mutation is expressed at the level of a stem cell. So Anne Mullally showed this very nicely in this review, that the key receptors are expressed at the level of the stem cell, and so are the key mutations. So what that means is that we need to consider what these mutations do in stem cell populations, and what they seem to do is to drive them to go down what's called the myeloid lineage, so to make white blood cells, red blood cells, or platelets. Now, what we understand is that there's also a microenvironmental influence that allows that mutated stem cell to gain hold and not only proliferate within the bone marrow, but also mobilize to other sites. And when you think of when William Demchuk described myeloproliferative disorders in 1951, he actually said it was as if the cells were responding to a myelostimulatory agent and going to other sites like the spleen. So these are primordial sites of blood development, and this is what was happening in MPN. So he had that prescient observation that there's a malignant niche that's self-reinforcing and allows this MPN stem cell to make more of itself. That's called self-renewal, but also to go to other sites, including the spleen and the liver. So, you know, we used to question whether or not a single stem cell could propagate disease. And then 2014, a group published that yes, indeed, a single stem cell that has the JAK2 V617F mutation can actually give rise to all blood cell lineages, red blood cells, platelets, granulocytes, and B cells. So this is a stem cell disorder. The issue is it's really difficult to predict which way a stem cell is going to go in terms of is it going to make more platelets? Is it going to make more red cells and give rise to polycythemia vera, or scar the bone marrow? So there's this heterogeneity of the MPN phenotype. And part of that is dictated by our germline genetic variation, other mutations, microenvironmental and now macroenvironmental factors, as a lot of us worry about COVID. And then the JAK2 mutation allele burden, as well as the level of mutations for other mutations, as Ruben alluded to with ASXL1. So, you know, we've been looking at this for quite a long time, that, you know, the stem cell can get a mutation, but one mutation can drive early myeloproliferation, but may not drive progression. And so Ruben, Mesa, and I and others were involved in a call earlier in the week to talk about the events involved in progression of myeloproliferative neoplasms all the way through myelofibrosis to acute myeloid leukemia. And it's clear that we need the initial mutation, for example, in JAK2, but then the cells need to be able to evade apoptosis so they don't die. The good news is that there's this new drug called navitoclax, which seems to be able to target BCL-XL. And so we're really excited about the clinical trials that are ongoing with this drug. You can lose tumor suppression and the cell can self-renew a little too easily. And this is a trial that Ruben and others are doing, targeting LSD1, which is a stem cell gene that enables aberrant self-renewal. And then we've got the BET inhibitors, specifically CPI-0610. I'll talk a little bit today about longevity. Some of these cells just live too long because of activation of telomerase and the TERT, telomerase reverse transcriptase. They can evade the immune system, both innate and adaptive, and ultimately learn to self-renew. So we have a number of new drugs, Dr. Mesa alluded to, Inrebic being approved. And of course, we have Jakafi, so we have two choices for people to begin with. Now what we're finding is as people progress, we need to think about combination therapy, targeting stem cell pathways, including the hedgehog pathway, and more recently, ROR1. We also want to know, why do people get these mutations? So we're starting to look at primate-specific mutating enzymes that are actually activated by inflammation and viral infection. These are the APOBEX and ADAR. So I'll talk a little bit about that. And then one very exciting recent approval is the approval of an antibody targeting the don't eat me signal called CD47. This was approved just a few days ago for high-risk myelodysplastic syndrome as it transitions to AML. And we know a lot of our patients with high-risk myelofibrosis have dysplastic features. So this may prevent progression in myelofibrosis, and those clinical trials will need to be performed. But this particular antibody called magrolimab was recently approved for high-risk MDS. So watch out for that one. And I'll talk a little bit about imetelstat, the telomerase inhibitor that a lot of us know about. So I wanted to get back to JAK2 inhibition. This is something that Dr. Mesa alluded to. We've known since about 2008 that selective JAK2 inhibition can inhibit polycythemia vera, as well as myelofibrosis. And there was a seminal study published by Claire Harrison and Ruben Mesa showing that in patients who hadn't responded adequately or were intolerant to ruxolitinib, they could actually respond to fedratinib. And this formed part of the basis for actually approving this JAK2 inhibitor called fedratinib. Now, this is a very potent JAK2 inhibitor, but you'll notice it also inhibits FLT3. So this is particularly good for people who are starting to develop what are called leukemia stem cells that upregulate FLT3. So they're not just reliant on JAK2 signaling, they also use FLT3. So this was approved in August of last year. People are getting it actually as first-line therapy or second line after not having an adequate response to ruxolitinib. Now, what about this microenvironment? What's going on in the bone marrow, and why do people allow these mutant clones to propagate? It looks like the innervation of the microenvironment is not appropriate in myeloproliferative neoplasms. And so they don't have proper sympathetic innervation. This was a very important paper by Radek Skoda and Mendez-Ferrer in Nature a few years ago. And it suggests that may be something that we need to consider targeting in myeloproliferative neoplasms, and that's the hematopoietic stem cell niche. I alluded to CD47. We've known for a few years that CD47, the don't eat me signal, is upregulated on MPN stem cells and their progenitors. And this prevents macrophages, that are the garbage trucks of the immune system, from eating those cells as they exit the bone marrow. If we knock down CD47, we're able to allow macrophages to see them. So CD47 is like the cloaking shield in Star Trek. It really prevents the macrophages from seeing these cells. If you get rid of CD47, the macrophages here in green can go and gobble up the cells and get rid of them. So this formed the basis for a clinical trial targeting macrophage immune checkpoint CD47 in myeloid malignancies, and led to the approval on September 15th, its breakthrough therapy designation approval for this first-in-class anti-CD47 antibody for patients with newly diagnosed myelodysplastic syndrome. And I'm bringing that up because really we discovered this marker in MPNs to begin with in preclinical models. So it may have a role in MPN. So watch out for that. There will be clinical trials. Now, what about our telomeres? So our telomeres are the ends of our chromosomes, and telomerase prevents the chromosomes from unraveling. This was discovered by Elizabeth Blackburn, and we decided to look at that in patients that have myeloproliferative neoplasms at the stem cell level. So we sorted stem and progenitor cells from patients, performed whole genome sequencing in people with PV, essential thrombocythemia, myelofibrosis, and then also did whole transcriptome or RNA sequencing on many of the same patients. So that was 100 samples. So I'll just take you through this. Basically, what we found was that there was telomere shortening at the level of the stem cell in PV, and this is why it's relevant to women with MPNs compared with men with MPNs. What we found at the stem cell level is women maintain their telomeres a little more effectively than men with MPNs, and this was significant in the stem cells, not in the saliva control. So we think that there's an important difference between men and women with MPNs in terms of how they shorten their telomeres. This means that their cells are undergoing accelerated aging. And what we see as telomere shortening at the stem cell level is even more prominent as people progress to high-risk myelofibrosis. And what you can see here is this correlates with TERT, telomerase reverse transcriptase expression, that goes up as people progress from PV or ET to myelofibrosis. So clearly, telomerase is a very important target in myelofibrosis. This was a seminal paper published by Ayalu Teferi and colleagues in the New England Journal a few years ago. And what's so striking is that they showed reversal of scarring or fibrosis with this antisense oligonucleotide inhibitor of telomerase called imetelstat. And this is still in clinical trials, so we need to keep an eye out for that. But what we were particularly interested in seeing is, does imetelstat reduce the capacity of what are called leukemia stem cells to propagate in myelofibrosis models, as well as leukemia models, and indeed is a very potent inhibitor of both pre-leukemia stem cells in MPNs, as well as leukemia stem cells. We could see with this drug, as suggested by Ayalu Teferi, a reduction in bone marrow scarring in our humanized mouse models of myelofibrosis. We decrease the human CD45 positive cells, as you see here in red, and we decrease engraftment, as well as increasing survival of those transplanted mice. So we think imetelstat is a very important agent for reducing the potential for progression that is driven by leukemia stem cells. Now, we're talking about women with MPNs, and a lot of women in my clinic on Wednesdays ask me if hormone replacement therapy could be detrimental, or if there is something that we should consider female specific actually when it comes to MPN. So there was a very important paper published in Cell Stem Cell showing that estrogen receptor alpha is actually expressed by hematopoietic stem and progenitor cells. And if you induce estrogen receptor, you can actually induce cell death in these populations. What they found was these estrogen receptor positive stem cells tend to proliferate too much when they have the JAK2 mutation. And you can block that with tamoxifen, the estrogen receptor blocker. So what that means is tamoxifen may have a role in the treatment of women with MPNs. There are ongoing clinical trials for this, but I think it's an important thing to consider that there may be real differences at the stem cell level in terms of MPN responses that we can take advantage of when it comes to treating women with MPNs. Now, the other thing we can take advantage of is a molecule called ADAR1. ADAR1 is on our radar because it seems to introduce changes at the RNA level that induce progression. The good news is this ADAR molecule seems to be blocked by JAK2 inhibition, be it with ruxolitinib or with our other drug, Froedtert. The other molecule that's in it, part of our innate immune response to protect us from viruses like SARS-CoV-2 is ApoBec3. ApoBec3 induces mutations in cancer in response to inflammatory growth factors. The Ruben, Mesa, and others have shown us are so important in MPN progression. So the question is, why didn't people study these more before? And the reason is you can't study these in a mouse model. They are primate specific, the ApoBec3s, and it turns out they induce mutagenesis in many types of cancer. Again, we looked at the MPN patients and found that ApoBec, and specifically 3C, is upregulated in people who progress from intermediate risk myelofibrosis to high risk myelofibrosis. And this ApoBec3C expands the hematopoietic stem and progenitor population. What we were really amazed by is the ApoBec3C mutational pattern that we see in MPNs at the stem cell level is recapitulated by overexpressing ApoBec3C lentivirally. So that's work done by Lyudmila Alexandrov and our lab. So we're pretty excited about that because we think ApoBec3C may initiate some of the mutations in MPN stem cells. Now, what happens with ApoBec and ADAR? Do they work together? And it turns out that they do work together. So it's the Bonnie and Clyde effect. We've got the DNA mutator ApoBec. We've got the RNA editing enzyme ADAR, and they work together. They actually bind to each other, and they work to corrupt the genome and the transcriptome together. So this Bonnie and Clyde effect leads to MPN stem cell evolution into leukemia stem cells. We've done this all by RNA sequencing, so I'll just go through this. Basically, what happens is you get ADAR upregulation, and in those cells, they overexpress both ADAR and ApoBec. So this is what I mean by the Bonnie and Clyde effect. They're both bad actors, and they're both upregulated in people with advanced MPNs. So what that does is it gives us very specific biomarkers of pre-leukemia stem cell or MPN stem cell evolution to leukemia stem cells because of very specific RNA editing patterns in genes like CDK13, which is a splicing gene. So we see CDK13 and ADAR coalescing in these cells. It looks like that editing is something that we can follow as a biomarker of progression. Why does ADAR matter? Well, it turns out it matters for a lot of different cancers. So we found that it's upregulated in MPNs as they progress to AML. But Gordon Mills and Han Liang showed in 2015 that ADAR-mediated editing is associated with worse outcomes in 17 different tumor types and is a marker of therapeutic resistance. Also, loss of ADAR in tumors overcomes resistance to immune checkpoint blockade. So that suggests that if interferon is overexpressed, it can activate ADAR and lead to therapeutic resistance to immune checkpoint blockade. If you remove ADAR, you lift that resistance and you're able to sensitize patients. Now, the other thing that ADAR, adenosine deaminase associated with RNA does is it actually changes splicing. And we've heard all about spliceosome modulators, but it turns out ADAR itself can change splicing when activated. So we and others have been interested in splicing modulation in MDS, MPNs, and AML. And when we look at splicing patterns or splice isoforms as biomarkers, we can really distinguish MDS and MPN overlap syndromes together with secondary AML from aged and young progenitors. These progenitors have isoforms that are really unique. They undergo what's called exon skipping and intron retention, and they kind of give themselves away based on these isoform gene expression differences. So what we've developed is a splice isoform reporter of cancer stem cell generation, where cancer stem cells or leukemia stem cells go from green to red as they corrupt the spliceosome. And you can see that in this video. So what we've done is we've actually developed a splicing modulator, and that splicing modulator inhibits this abnormal splicing in secondary AML compared to normal cells here in the red and D. The secondary AML that has evolved from MPNs, those samples are exquisitely sensitive to the splicing modulator. So we've done this in humanized mouse models. We find that there's a very good response in the bone marrow and the spleen with the splicing modulator, and that overall we have a reduction in the leukemia stem cell propagation from MPNs. This drug is called 17S-FT895. We just filed the pre-IND documents. We're trying to call it Rebexinib after Rebecca, the person who helped to fund some of this work. And the ideal outcome would be to reverse the leukemia stem cell propagation and allow people to go back to normal aged stem cells to restore the balance. The final thing I wanted to mention, and this is sort of a departure from anything we've ever done before, is a program we're launching, pun intended, called the Integrated Space Stem Cell Orbital Research Lab, iSCORE Lab, to study stem cell biology in low Earth orbit. And some of you may remember the twin study that was published in April 2019 that showed that Scott Kelly, who had been up on orbit in low Earth orbit for almost a year, developed some pre-malignant changes in his blood, including translocations, but also he had evidence of telomere lengthening showing he'd activated telomerase. So what we've done is actually plan to study hematopoietic stem cell aging and immune dysregulation in bioreactors on the International Space Station, funded by NASA in collaboration with a company called Space Tango, to see if we can investigate MPN initiation in response to the higher levels of ionizing radiation that are seen in low Earth orbit, in addition to inflammatory cytokine inducing influences. So ideally, what we'd like to do in the MPN field, now that we've gained so much traction in early and intermediate stage disease, is stop progression of intermediate stage to high-risk disease and stop progression to AML by inhibiting some of these stem cell pathways. And so we're really excited to keep working with you and with other members of the MPN community. Ruben and Claire have been stalwart champions for patients, and they're very heartened to know that you've been working so hard to do this. We've been funded by the California Institute for Regenerative Medicine, the NCI, NIDDK, Leukemia Lymphoma Society, the MPN Research Foundation, and very recently NASA. We have very excited people in the lab who work really hard. And so I'm so glad to be able to present this to you today. I know it's a lot of stem cell work, but I think that is the root cause of MPNs, and I know you've had to hear that ad nauseum, as has our friend Ruben.
No, I mean, you know what, Catriona, you know how much I adore you, and your work is just phenomenal. This is always such a great time for all of us, because to see how many smart people are involved in making the world for MPN patients and even their caregivers, of course, and families, just easier. I mean, the day is coming. We have so many drugs in the pipeline, and so many more people are having stem cell transplants, and the work that you're doing is absolutely phenomenal. I want to know more about this NASA thing. That is fantastic. Wow.
Yeah.
I mean, who'd have thought?
I mean, who would have thought? I mean, NASA is very interested in using the low Earth orbit, they call it LEO environment, because there's more ionizing radiation up there, to study bone marrow disorders that may derive from increased radiation over a lifespan, but also inflammatory mediators that are actually sort of concentrated on the International Space Station. Apparently, it's not that clean an environment. So you can study aging in 1 year to the extent that it would happen on Earth in about 10 years. So it's an opportunity to study stem cell aging and to see if it goes awry, as unfortunately it looked like it did in Scott Kelly. So we'd really like to follow up with Scott Kelly so we can use the space environment to inform us about how these disorders initiate on Earth, but also to protect people that plan to be going up into space fairly routinely. It's 250 miles above Earth, but it's becoming an area to do not just research, but drug development, X-ray crystallography, stem cell expansion. So we want to protect the people that go up there.
Right. I have so many questions for you, so I'm going to hit those for you because I know you have to get back to your patients in your lab. Do you think CRISPR will eliminate the need for stem cell transplant?
That's why I brought up the APOBEC and ADAR stories. I know it seems sort of erudite or somehow abstract at this point, but ADAR and APOBEC are our natural CRISPRs. So what is CRISPR? CRISPR is a method that bacteria use to fight viruses. In bacteria, those are called bacteriophage. And so they use CRISPR to be the sushi chef for those bacteriophage. Well, we have our own sushi chefs in our stem cells. They're called APOBEC and ADAR. If you have CRISPR in a lentiviral vector and it gets into cells too much, it's going to activate these mutators, APOBEC and ADAR, and we may get editing of our stem cells in a bad way. So we actually need to monitor our own CRISPRs, APOBECs, and ADAR to make sure that there aren't off-target effects from CRISPR. But because we know how to look for this now, we can work together with people who are developing CRISPR technology, like Jennifer Doudna and others who have actually, Carl June, who have made this relevant to make sure it's not mutating our stem cells. So we have the biomarkers now. I think CRISPR is the way of the future. We just have to be careful about how we use it and make sure that we can turn it off when we need to. And I think we can, based on JAK2 inhibition potentially, but also with some newer agents that are getting developed to block APOBEC and ADAR.
Absolutely. And actually, she was going to speak at our event in Boston last year. Jennifer was. So very interesting. And so moving right along, how would these new potential drug treatments affect a triple negative patient with no JAK2 mutations and no CALR or MPL mutation?
Yeah, so that's about 20% of people. And, that's always the difficult thing. We can't find a clonal mutation that's an obvious driver. And what we're starting to see is there's splicing deregulation in those patients in the absence of splicing factor mutations. And also we're seeing RNA editing activation through ADAR in some of those patients. We can target the RNA editing with a JAK2 inhibitor, but with the splicing changes, we really do need a splicing modulator or inhibitor. And, it's not just us, obviously, that are developing splicing modulators. There's one made by H3 Biomedicines that is transiting through clinical trials. It has been used in CMML and MDS, but to my knowledge, not in MPNs. And I think that would be a very good place to use it. Certainly that's the place we'd like to take this because it's really tough for patients to go, wait a minute, I don't have a JAK2 mutation, MPL mutation, CALR mutation. How am I ever going to respond to an inhibitor? The other thing that Ruben alluded to is LSD1 is actually altered in some people who have the triple negative phenotype. And then with ASXL1, we may be able to use a BET inhibitor. So I think, Ross Levine and others who have helped to develop the BET inhibitors, use them in combination with JAK2 inhibitors, are really helping out the MPN community. And I'm betting that that's going to be a great approach, the BET inhibition approach.
I have a few more questions. And one is, we've been doing a lot of work with pediatric MPN patients and younger patients, 30 and under. And the question is, in younger patients, what is the sweet spot in terms of being the right amount of sick to not too sick for a successful transplant?
That is a really interesting question because what we're studying now is pediatric AML, is pediatric and adolescent AML that derives from MPNs. And so that looks very much like secondary AML in adults, in older adults. And what they have is upregulation of a pro-survival isoform called MCL1. It's highly upregulated and susceptible to the splicing modulator. So their disease looks like secondary AML, and I think we should think about combination strategies with BCL2 family member antagonists like venetoclax, or more recently navitoclax. That looks very exciting, but also potentially the splicing modulator. I don't think everybody has to go to transplant immediately. I see a lot of these young folks in my clinic. The youngest patient I have in my clinic is 21. I have a patient with grade 3 myelofibrosis, 26. I have some younger patients. They don't necessarily all want to go to transplant. Hematopoietic cell transplant is associated with graft versus host disease and other untoward effects. And if you've scarred down your bone marrow, doesn't necessarily work that well. So ideally, we'd want to use an agent that reduces bone marrow scarring, whether it's navitoclax, imetelstat, and then do the transplant. So in terms of the question, what is the right amount of sick? The least amount of sick is the right amount of sick. And if we can get their scarring down with these newer agents that Dr. Mesa was talking about, I think they'll be in better shape for a transplant if they decide they want to go that way. We just want to clear out the scarring in the bone marrow as much as possible before going down that road.
Another question, that I was very involved with some of the environmental and chemical issues related to, the possible relationship between environmental issues and MPNs. And not only in the Tri-County area in Pennsylvania, but also with Vietnam veterans who were exposed to Agent Orange. We're still working on those issues. This question is, what are your thoughts about growing up near a toxic waste plant, or a plant that is emitting, toxins, and the percentages or the rate of people that might acquire an MPN later?
Yeah, this is a fundamental question that I think we're all grappling with in the field. What have we been exposed to as kids based on where we grew up? So my dad was a coal mining engineer, so I'm a coal miner's daughter, and we lived next to an orange pond. It was brilliant orange. It was actually quite a nice orange. But it was, I'm sure, very toxic. And we didn't think that might be seeping into the water. So I think for a lot of us, we've grown up somewhat in toxic environments or taken on occupations where we're more exposed to radiation or other toxic compounds. I think part of this is a genetic predisposition to not recognize these abnormal cells that mutated in part because of the toxic environment. And that's what we're finding with our sequencing. So there are natural killer cell haplotypes, KIR haplotypes, that seem to be associated with people who get MPNs and progress. And so I think knowing about that to begin with is important. I think we'll be doing whole genome sequencing in the future to see what is our inherent genetic risk, not just ourselves, but also for our families. And then in terms of local exposures, and you've been such a champion for trying to clean up the environment, or at least alert people to the fact that they live next to a toxic waste site. My concern at the moment are decommissioned nuclear plants. So, I'm a little concerned that I can see 15 patients every Wednesday with myelofibrosis. And we live close to San Onofre. San Onofre is decommissioned, but it doesn't mean the nuclear material is completely spent. And intermittently, they release cesium-137 into the air and cobalt-60 into the water. I don't think it's a coincidence that we have more cases of myelofibrosis here. So I share your concern. I think that the main thing is, if you can move away from that site, move away. It can get into the water, it can get into the air, but the bottom line is we can detect these changes early, and the earlier we start to intervene with these mutations, the better.
Yes, and in Philadelphia, it was Superfund sites that were left with 7,000 plus tons of toxic waste. And in that 3-mile area, there were lots and lots of people with polycythemia vera. So it was pretty obvious that there was a connection. But okay, so we have other questions that I'm going to email to you, and we will get those in our newsletters and on our website. And I thank you with all my heart for taking the time to do this. We always appreciate this greatly, the time that our presenters take away from patients in the lab. So thank you, Catriona. It was wonderful.
Thank you so much, Anne. It's always great to see you and our friends in the MPN research community and to focus on women and MPNs.
Yes, yes, very near and dear to my heart. Thank you again.
Appreciate it.
So we will move along now. This is when we have allotted some time for our industry partners. And I'd like to say a few words about these partners of ours. They not only support MPN Advocacy and Education International, which is us. So these educational programs would not be possible without them, without their support. But they also support probably all or most of the MPN community organizations that you deal with or read about or go to their websites. They are extremely supportive, but not only have they been supportive, but they're also working really hard on trying to find new drug treatments for the MPN community. There are two that are already commercialized in Rebic with Bristol Myers Squibb now, and Jakafi with Incyte Corporation, which has now been around, I think, 8 years. I could be wrong. But we thank them from the bottom of our hearts. We could not do the work we do without them. And that includes a lot of the advocacy work Kathleen and Ariel and I do as a team here. It's just a small group, but we're pretty agile. And but also the bigger groups that they support that are able to provide a lot of resources for all of you. So I want to give them a little bit of airtime here. And our first partner on our list here is Kristen Griffiths, who's the Senior Manager for U.S. Public Affairs with Incyte Corporation. Kristen?
Hello, can you hear me?
Yes, I can.
Okay, great. So thank you so much for the opportunity. I am so pleased to be here today to represent Incyte, and I'd like to thank Anne and the team at MPN Advocacy and Education International for having me and take a few moments to speak about our company and our commitment to patients. So just first, a little bit of background on Incyte. So Incyte is a Wilmington, Delaware-based biopharmaceutical company committed to making the difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do to discover and develop novel medicines that really meet the serious medical needs in oncology and other diseases. So we are committed to providing better outcomes for the patients through the medicines that we develop and education that we provide to support the community. Just a little bit about patient access. So one of our most important commitments is to help ensure that appropriate patients may have access to the medicines that we produce. And for this reason, we've developed a patient program called Incyte Cares. And this is to help assist appropriate patients and healthcare providers access our products. So Incyte Cares offers prescription verification, prior authorization support. We offer free drug and copay insurance for those who qualify. And of course, there's terms and conditions that may apply. Referral to independent nonprofit organizations or foundations that may help provide financial assistance, as well as ongoing educational support and opportunities to speak with a registered nurse. So I highly encourage patients who have concerns about access to contact Incyte Cares for assistance. And then just a little bit about our patient community support. So we really strive to support the patient community and integrate the authentic patient voice throughout our initiatives. So partnerships like the one we have with MPN Advocacy and Education International have really been key in helping us understand the unmet patient need as well as the caregiver needs, including raising disease awareness and providing educational support for the community. One important website that I want to make sure you all are aware of is voicesofmpn.com. Voices of MPN is a website where we provide lots of MPN information, patient stories, and access to MPN community events such as Facebook Lives and patient meetings, podcasts, as well as a symptom tracker. So please check that out. We also just launched our recent campaign, Rare Reflections, where we're partnering with a MPN patient as well as comic book artist, J.G. Jones, who really transforms the patient story through the power of his artwork. And it's a beautiful campaign, so I highly recommend it. So in closing today, I just want to mention that we at Insight, we really believe that the industry and the patient groups, we have this wonderful opportunity to find a common ground to help develop collaborative patient relationships resulting in meaningful activities. And we just want to say thank you again for programs like this that really allow Insight to use our resources to help improve the lives and individuals for those who are impacted in the diseases in which we do our work. So thank you so much.
Thank you very much. We couldn't do it without your support. So thank you very much, Kristen.
You're welcome.
So we will move along now, and AbbVie is one of our partners, and we're very pleased that they're with us. And Brian Murray, who is the Assistant Scientific Director, please give us a little update.
All right, thank you so much. Hi everyone, my name is Brian Murray. I'm an Assistant Scientific Director at AbbVie. AbbVie is a global pharmaceutical company, a leader in the transformation of care for patients with blood cancers. We're striving to advance standards of care and bring transformative treatment options to patients, including those with myelofibrosis. I want to thank the organizers for allowing me time today, and I really appreciate all the work that you've all done to make this conference a success. So AbbVie is currently evaluating navitoclax in myelofibrosis. And you heard about navitoclax earlier from Dr. Mesa this morning, gave a great presentation on emerging treatments. Navitoclax is an investigational agent not currently FDA approved. It's a first-in-class oral small molecule that binds to two proteins called BCL-XL and BCL-2. These are pro-survival proteins that prevent cells from dying, and cancer cells can hijack these proteins and their associated pathways to keep themselves alive. And so we've done work showing that BCL-XL could play an important role in myelofibrosis, including driving the disease. And we've also generated some preclinical data suggesting that navitoclax may work well in combination with JAK2 inhibitors, such as ruxolitinib, to overcome resistance to these agents and potentially benefit patients with this disease. And so we're doing a number of clinical trials in this setting. We have an ongoing phase 2 study that's currently active and enrolling in the United States, evaluating the efficacy and safety of navitoclax in myelofibrosis, and Dr. Mesa presented some of those results earlier this morning. These results were presented both last summer at EHA and then at ASH last year as well. And so we're enrolling patients in this study who have received prior treatment with ruxolitinib or another JAK2 inhibitor, as well as patients who have not received treatment with a prior JAK2 inhibitor. As I'd mentioned, the study is active and enrolling in the United States as well as globally, and we have about 25 sites in the United States for this study. We also have 2 phase 3 studies evaluating the combination of navitoclax and ruxolitinib in myelofibrosis. The first phase 3 study I'll discuss, Transform-1, is a study that will include patients who have not received prior treatment with a JAK2 inhibitor, and will evaluate the combination of navitoclax and ruxolitinib versus ruxolitinib and placebo. Patients who are eligible include those who are of intermediate 2 risk, have a palpable spleen, have platelets over 100,000 per microliter, and they must be transplant ineligible. The second study that is now active is called Transform-2, and this is another phase 3 trial evaluating the combination of navitoclax and ruxolitinib in patients who have worsening disease despite previous or current treatment with the JAK2 inhibitor. This study, again, will evaluate navitoclax in combination with ruxolitinib versus best available therapy, which is at the discretion of the treating physician, but could include ruxolitinib, fedratinib, and other agents as well. We've just started activating sites for both of these trials in the United States, and will continue to open sites this month and through the remainder of the fall and winter. We're planning for about 130 plus sites for each trial, and you can find more information on these trials at clinicaltrials.gov or AbbVie.com. Thank you for your time.
So much. I really appreciated that, Brian. We really appreciate your support as well. So moving along, we have Laura Eichhorn, who is the COO and CFO of Imago Biosciences, who have supported us for many years, and we so appreciate it. Laura?
Super. So I think my video is coming up, and I'm going to go ahead and get started. First, I just wanted to thank Anne, Kathleen, and Ariel, and the entire MPN advocacy team for your tireless dedication to this community. This event in particular, the Women in MPN meeting, is kind of near and dear to our company's heart, given that we are comprised of over 75% women in our company. So it's a special event for us. So we're honored to continue to support this year after year. I would just want to take a few minutes to share with you my experience with Anne. I'm constantly inspired and tired almost personally by her commitment, because she has the energy of 1,000 people. I'm impressed with her passion to provide support and information to each of you, and I strongly encourage you to continue to use Anne and her team as a resource, whether it's for help for financial support, to get to your visits with your physician, or to connect with a specialist, or to learn more about yoga, or different ways to change your diet. So she's an incredible resource, and we're proud as a company to continue to support this organization. A little bit about our company. Imago Biosciences is a private company. We were founded in 2012. We're currently focused on the treatment of myeloproliferative neoplasms. These are a family of diseases, as you know, that pose a great challenge, and there is a significant area of unmet need that we feel that our drug would continue to support. Our drug is called bomedemstat, or IMG 7289, and we discovered this in 2015. It's an oral medication taken once daily. We began our research in patients with leukemia in 2016. So bomedemstat inhibits an enzyme that regulates the maturation of blood cells in the bone marrow. It's the goal of our therapy in myelofibrosis to improve symptoms and reduce spleen size and reduce the number of malignant cells. For those with essential thrombocythemia, the goals are similar, including reducing the platelet count to normal. Bomedemstat was designated by the FDA for fast track approval for the treatment of both myelofibrosis and essential thrombocythemia, and more recently, bomedemstat was granted PRIME status in the EU. For the treatment of myelofibrosis, Imago conducted first a small phase 2A trial in 18 patients to understand the safety and efficacy and dosing of bomedemstat taken daily for 12 weeks. At that time, there were no safety signals, and most patients experienced improvement in their symptoms and shrinkage of their spleens. So these results encourage us to move forward, and we are now firmly entrenched in our phase 2B portion of that trial, enrolling both in the US and globally. We are more than halfway enrolled, and that study is a 6-month study of patients, 6-month treatment study. And the starting dose is a little bit higher in this 2B portion, with the belief that this will lead to a more rapid improvement in the symptoms and reduction in their spleen size. Dr. Kristen Pettit from the University of Michigan and an investigator on this study presented data at the June EHA event. An abstract of this highlights the current data demonstrating a reduction in spleen volume and continued improvement in symptom scores, and this is available online on our website, www.imagobio.com. In this study, most patients also had a stable or improved bone marrow fibrosis score and hemoglobin. So therefore, overall preliminary data in this ongoing study shows that bomedemstat is generally well tolerated in a diverse population of patients with advanced myelofibrosis with limited therapeutic options. This study has also been expanded and continued to open sites, patients at sites in the US, Europe, and in Asia. We recently opened a study in June of this year in the research in essential thrombocythemia. This study currently has 11 sites open, with more sites opening on a daily basis. We will enroll up to 60 patients in this study, and we hope to announce the enrollment of that first patient very soon. Bomedemstat is also being tested for the treatment of polycythemia vera at the University of Miami. In the coming months, we will also launch a study in combination with ruxolitinib and bomedemstat for the treatment of myelofibrosis to determine if there's any additional clinical benefit of those two agents together. Thank you all for joining this meeting today. And if you're interested in learning more about Imago, please visit our website or our clinical study site, www.myelofibrosisclinicalstudy.com. Thanks, Anne.
Thank you so much, Laura, for those very kind words and for that information. You're doing good work. Thank you so much. So
Thank
moving
you.
along, you're welcome. Sierra Oncology is one of our newer partners, and they've been wonderful to us, and we really appreciate the work that they're doing. Dr. Barb Klinecki will be speaking to you briefly. She's the Chief Development Officer. Barb?
So thanks. I'm Dr. Barbara Klinecki. I'm a medical oncologist, and I'm also the Chief Development Officer at Sierra. So Sierra Oncology is a late stage biotechnology company. We're focused on bringing targeted therapies to patients with high unmet medical needs. Our main focus is the development of momelotinib. This is an investigational agent that Dr. Ruben Mesa mentioned earlier today, and we're developing it for the treatment of myelofibrosis. Momelotinib is an inhibitor of 3 key signaling pathways that contribute to the major manifestations of this disease. So by inhibiting JAK1, JAK2, and ACVR1, we believe that momelotinib has the potential to improve the anemia of myelofibrosis, along with improving symptoms and splenomegaly. We're currently enrolling patients to our ongoing phase 3 trial that we call the Momentum trial. The trial compares the activity of momelotinib to another treatment called danazol, and it will assess the impact of momelotinib on symptoms, on anemia, on blood transfusions, on spleen size, and on safety of the product. The trial is now open in 21 countries, at over 100 sites, including 15 in the United States. We expect the results from this trial to be available in 2022. If the study is positive, regulatory authorities would then have to review and approve the product before it could become commercially available. For more information, you can check our corporate website at www.sierraoncology.com. So just in closing, I wanted to thank Anne and your organization for all that you do for patients and this opportunity to tell your listeners about Sierra Oncology. So thanks for your interest.
Oh, thank you very much, Barb. We truly appreciate your support and the work that you're doing as well. Thank you. So now we will hear from Dr. Faye Feller from Geron Corporation. Faye is the Vice President of Clinical Development. I actually met her several years ago, and I'm happy to see her today. Hi, Faye. Thank you for doing this.
Hi, Anne. Good afternoon. Good afternoon, everyone. Thank you, Anne, and MPN Advocacy for having me today. We're really honored to be here, and I'm honored to be here representing Geron. The talks and presentations have been really interesting and informative. As Anne said, my name is Faye Feller. I'm a trained hematologist and the head of clinical development at Geron. We are a late-stage biopharmaceutical company developing imetelstat, which you also just recently heard about in Dr. Jamieson's talk. Imetelstat is a telomerase inhibitor, and we are studying it in hematologic myeloid malignancies, as well as especially MPNs and MF primarily, myelofibrosis. We recently completed a phase 2 study of imetelstat in intermediate 2 and high-risk myelofibrosis patients who are relapsed after or refractory to treatment with JAK inhibitor. The study, known as MYF 2001 or EMBARK, showed a potential for survival benefit and an encouraging symptom response rate. Subsequently, we are currently in the process of opening a phase 3 randomized controlled trial in intermediate 2 and high-risk myelofibrosis patients who are refractory to JAK inhibitor treatment. This study is known as MYF 3001 and is an open-label randomized controlled trial comparing imetelstat to best available therapy. The primary endpoint for the trial is overall survival, and symptom response rate is a key secondary endpoint. We plan on over 100 sites to be open globally and look forward to continuing to bring imetelstat to myelofibrosis patients. Thank you for this time and for the opportunity to speak about Geron and about imetelstat.
Thank you very much, Faye. We really appreciated it. And we're going to move right along to Bristol Myers Squibb, I'm sorry. Gina Kramer, who is the clinical nurse consultant.
Thank you. Well, thank you for having me. My name's Gina Kramer, and I'm a clinical nurse consultant with Bristol Myers Squibb. I've been a nurse for 34 years in the hematology blood cancer space. And today I'm very excited to speak with you about a newly launched resource for patients and caregivers. The website is seehearspeakmf.com. Hopefully you've had the opportunity to view the video that was sent to you prior to this session. Now I would just like to quickly share some highlights and walk you through some of those highlights from this site. As a nurse, I cannot stress enough how vital it is for you as patients to use your voice and to be heard. You and your voice are very powerful. Your voice can be used to share your story. A very important part of your story is recognizing and sharing your symptoms with your healthcare providers, your physicians, and your nurses. And you might be thinking, how can I do that? On the See, Hear, Speak website, there is a tool that can help you identify those common symptoms from a list to track those symptoms. It's called the Symptom Tracking Tool. You can identify those symptoms with a date, and not only identify them, but you can grade them on the severity that you as an individual are experiencing them and rate them from 1 to 10. So what's next? So you've identified your symptoms, you've rated those. You need to share that with your physician and nurse at a visit and utilize that in your conversation with your healthcare provider. Reporting and sharing changes in your symptoms can play a very important key role in assisting your healthcare providers in managing your myelofibrosis. So why is this important? As many of you are aware, several symptoms associated with myelofibrosis can be determined from lab results, but there are some that can only be recognized by you as the patient. The first step is having the patient recognize those symptoms. For example, early satiety, that feeling full quickly after you eat. The symptom tracking tool is a great resource for you to use your voice and for you to be empowered. Often when I was in clinical practice, I would remind my patients that there's some symptoms like peripheral neuropathy that they have to tell me they're experiencing. And I would say to them gently, if you don't tell me, I don't know that they are experiencing them. So you don't need permission to share these symptoms. It is your right to share them. Also, asking clear questions is another way to use your voice and to become more informed. On the See, Hear, Speak site, you can access a discussion guide that contains sample questions that can assist you in speaking up and getting answers to your questions during your appointments, or even using those questions in between when you're calling your nurse as something may be new, as you want to report that prior to your next appointment. This tool can be utilized to ask questions that you have had between your appointments. Lastly, self-care is very important. It's also very key for caregivers to take care of themselves, to take care of others. On this site, you can also utilize great tips in this area, such as journaling and connecting with others who are walking the same journey. So thank you for your time and attention, and I encourage you to utilize the See, Hear, Speak site, and I appreciate the opportunity, Anne, to share this new resources for patients and caregivers. And thank you for all you do with your organization.
Thanks, Gina. And I've seen the literature. It's fantastic. So good job. To our friend at CTI Biopharma, Jim Fong, who is the Senior Vice President of Global Operations. I've known Jim for 100 years, it seems, no offense, but it sure seems like that. But anyway, the last time, many of us today, the last time we saw each other was just before the COVID pandemic made all of us stay home, and we happened to be in San Francisco. Thankfully, we were all very safe. But Jim, please give us an update on CTI Biopharma's work and what's happening.
Great. Well, thanks, Anne. And we are so thrilled and honored to be part of the 6th Annual Women in NPN Conference here. And thank you to Anne for inviting us. But as she just mentioned, I'm here at CTI Biopharma, and we are currently developing pacritinib, which is a JAK2 IRAK1 inhibitor for patients with myelofibrosis who have severe thrombocytopenia. And I'd like to take a few minutes to tell you about pacritinib and about the phase 3 trial Pacifica, which is actually currently open to enrollment. Pacritinib has been studied in over 1,200 patients, including 2 phase 3 studies in patients with myelofibrosis called PERSIST-1 and PERSIST-2. In both studies, pacritinib was more effective than best available therapy in reducing spleen volume. Both of the PERSIST studies included patients with severe thrombocytopenia, defined as platelet counts less than 50,000. This is a very important point because patients with myelofibrosis and severe thrombocytopenia often have greater symptom and disease burden than patients with higher platelet counts. We also know that treatment options for these patients with severe thrombocytopenia are certainly limited and unfortunately are often excluded from participating in clinical trials. We recognize that these patients face a serious unmet medical need, and there's a clear need for effective and safe therapies. So let's turn to the Pacifica study. The Pacifica study, as I mentioned, is open and it's enrolling patients with myelofibrosis and platelet counts less than 50,000. This study is open to patients who have either had no prior exposure to JAK inhibitors or who have had limited prior exposure. Patients with up to 6 months prior exposure may be eligible for our trial. The study enrolls patients who have both splenomegaly and symptoms related to myelofibrosis. Patients are randomized 2-to-1 to pacritinib versus physician's choice, and physician's choice includes ruxolitinib, danazol, hydroxyurea, and corticosteroids. This means that for every patient randomized to the control arm, 2 will be randomized to the pacritinib arm. Enrollment is now underway in the United States as well as worldwide, and we'll have about 140 sites open by the end of the year. In the US, we'll have approximately 50 sites open. The goal of the Pacifica study is to develop a therapy for a group that otherwise lacks alternative options in this severely thrombocytopenic population. If you need more information, please go to clinicaltrials.gov or go to the CTI Biopharma site, which is ctibiopharma.com. Thank you all so much for this time.
Thank you, Jim. We really appreciate it. Thank you.
Thank you, Ann.
So we are going to move on to Kartos, and Beth Mischling is the Senior VP of Medical Affairs. And you're coming to us from Colorado?
I am from Denver. It's such a pleasure to see you, Ann and Kathleen. Thank you as well for having us. My name is Beth Meckling, and I'm responsible for medical affairs for Kartos Therapeutics. And Kartos is probably the newest company on the block in development in myelofibrosis. We recently were established in 2018 and have KRT-232, which is an MDM2 inhibitor. We opened up our first trial in myelofibrosis in the middle of 2018 and enrolled our first patient on that trial in January of 2019. And recently reported those findings at EHA this summer by Professor Haifa Ali. So a little bit about the company. We're very small. We are 60 strong in Redwood City, California, and we're all committed to studying KRT-232, and a significant portion of that study is in myeloproliferative neoplasms. We have 4 MF trials that are running or in startup, and a trial that's looking at AML secondary to MPNs as well. So a lot going on. What is KRT-232? So it is an MDM2 inhibitor, and it is really focused on cell death. So it's a cell death agent that induces apoptosis of malignant myeloid cells in a p53-directed manner through activation of cell death pathways, specifically P21, PUMA, NOXA, and BAX. So a different mechanism than many of you have heard of. It's in the chart that Dr. Mesa showed under apoptotic agents, so similar mechanistically for apoptosis to navitoclax, which you heard about previously. So the first clinical proof of concept study was presented by Dr. Haifa Ali in Germany, and this was in 82 patients globally across 71 centers. And we have what we think is exciting signals, not only in the spleen, reduction of symptoms, as well as reduction of the malignant CD34 stem cells, significantly about 87% compared to baseline, which we think is also very exciting, as well as cytokines. So based on that study, we're opening a phase 3 trial that will be done globally across 100 sites. This opens up in the next month. to look at patients that have relapsed or refractory myelofibrosis to a JAK inhibitor, and that will be compared to best available therapy. So that trial should be opening up at about 25 to 30 sites in the United States, and then Asia Pac and Europe as well. We're very much looking forward to continuing to be the new kid on the block and investigating MDM2 inhibition and its importance in the treatment of myelofibrosis. And look forward to seeing most of you live, hopefully soon, at an upcoming event. Thank you.
Thank you so much. And we certainly hope we get to see everybody in person next year, probably. But be safe in Colorado, and thanks again. I really appreciate your support very much.
You bet, Ann. Thank you.
So we're going to move on to Constellation, who is a relatively new partner, and Dr. Catriona Luptakova, which is a lovely name.
Thank you very much, and thank you, Anne, for the opportunity to be here today. I was going to use the term that Beth just stole from me of saying we are the new kid on the block, at least me personally. But then I also realized that while me personally, I'm relatively new to this community, Constellation as a company is a Massachusetts-based biotech company with over 12 years of discovery and development history, focused on epigenetics and cancer biology. And our drug candidates, which were all internally discovered, are the product of our expertise in gene targeting, and specifically in diseases where gene regulation matters. One disease area where we are actively working on, and one that's especially important to the audience today, is myelofibrosis. And in fact, for me personally, recognizing the unmet need in this disease space from my prior experience at the bedside, because I'm a malignant hematologist, was a strong motivation for me to join Constellation. Our lead compound is an investigational BET inhibitor, CPI-610, and we are developing it as a potential treatment of myelofibrosis. As you know, this disease is characterized by changes in the bone marrow and several clinical hallmarks of the disease that include an enlarged spleen, constitutional symptoms such as fatigue and night sweats, on the laboratory end anemia, and histologically, it is characterized by bone marrow fibrosis. Taken together, we think of this as 4 hallmarks of myelofibrosis. Currently approved therapies have an effect on spleen and symptoms, but fundamentally, myelofibrosis is a disease characterized by worsening bone marrow function, and thus there remains significant need to improve the other 2 hallmarks, anemia and bone marrow fibrosis. Anemia remains a significant factor limiting doses on certain medications and can result in significant burden to many patients due to the need for transfusion support. And therefore, we are very excited to explore ways by which inhibiting BET proteins can deliver improvement across all of the hallmarks of myelofibrosis. Constellation is currently conducting a phase 2 clinical trial of our BET inhibitor, CPI-610, in myelofibrosis. And importantly, a larger global phase 3 trial is set to begin very soon. At Constellation, our clinical and research teams are deeply invested in a scientific approach to bringing therapies to patients. Our interest and commitment to patients and caregivers extends across the entire myeloproliferative community. And we have additionally early stage programs that might have further utility in myelofibrosis and other myeloproliferative neoplasm. I would like to conclude by once again thanking for the privilege of being here today. And we are very much looking forward to long-term and strong partnership because this is a team approach and we need to all work together.
That is absolutely correct. And thank you so very much. We really appreciate it, Catriona. Our person from Protagonist, Tracy Woods, is the Executive Vice President.
Thank you very much. Like a couple of former speakers, we are fairly new to this platform as well. So I work for Protagonist Therapeutics, and I really want to thank the MPN Advocacy and Educational International for hosting the 6th annual Women in MPN Conference. This is our first time, and I just found the speakers so interesting and compelling, and really enjoyed it. And just enjoyed also just hearing the colleagues in my industry who all, I think, share this common goal of improving the lives of people suffering from MPN. Protagonist is also, as mentioned before, a couple other companies. We're headquartered in the San Francisco Bay Area. We focus exclusively on the development of peptide therapeutics, and we have a highly innovative technology that allowed us to discover different drug candidates really against almost any biological target and disease of interest. But of course, today I'll just briefly tell you about our efforts that are specifically in polycythemia vera with what we call PTG-300. Briefly, the mechanism of action for PTG-300 is compelling and specific and unique. 300 is a peptide that mimics the natural hormone hepcidin, which we heard about today. Hepcidin has an established role in retaining iron cells in macrophages, decreasing iron availability for the production of red blood cells. PTG-300 is believed to limit excess production of red blood cells by storing iron in the macrophages. So that's just a little bit about the technology. I'll just quickly say that in May of this year, we announced positive data in the initial read from the first 7 patients treated in our open label phase 2b study. And in this study, patients were receiving weekly sub-Q injections of 300 with dose adjustments individually for every 4 weeks. And the study was designed similar to what we heard today to continue to keep patients below a hematocrit of 45. We are continuing with this study, and we are working closely with advocates and others advocacy organizations to announce that we continue to study up to hope to get about 50 patients enrolled, and we've expanded the number of centers in the United States as well. So, in closing, we're committed to bringing these new treatment options with polycythemia vera, encouraged by our data. And you can learn more about the Protagonist trial in our company at protagonisttherapeutics.com, or specifically by going on Ann's site to look at more information about the trial as well. So thank you all, and thank you for your patience on the technology.
Thank you so very much, Tracy. We really appreciated your time in doing this and your support. Protagonist Therapeutics is another one of our supporters, and we're very grateful. Thank you, Tracy. And so here we are. I just want to say thank you to all of those people that stayed this whole time and watched this program, our 6th annual Women in MPN program. We had over really close to 300 people registered, and we truly appreciate it. We have been doing these for free, and we thank our physicians and clinicians who have done this for us for years, without ever asking for any extra money, for anything extra from us, except to help support you, the patient and the caregiver. And to all of our sponsors, I can't thank you enough. Our partners have been phenomenal, and in all the things that they do. As I mentioned, their support is great, but also the work that they're doing in their labs to help the MPN community. So at this time, Dr. Michelle Corey was going to be with us, but is unable to do so. But she presented last year in Boston at our 5th annual Women in MPN program. And I saw a few questions about menopause and MPNs and some other questions that came up. She addresses each and every one of those in her presentation from last year. So we talked to her and she said, you know what, just run the video from last year, which is on our website, but our tech crew is going to start it in a few minutes when I'm done here. You can stay and watch it where you are, or you can go to our website at MPN Advocacy/videos, and you will find her there as well. But if you're relaxed and comfy and want to watch it, you can. And I believe there are questions for her during that time as well. But she does a phenomenal job. And by the way, she's also a patient. And so she gets it. She knows everything that you women are going through, that are experiencing, you know, each phase of your lives living with an MPN. So it would behoove you to watch this video. But in the meantime, we thank you with all our hearts also for being with us today. We'll be back next month and the month thereafter. We're going to try to do a program a webinar once a month until December. And when ASH is completed, which is all going to be online, we'll have our dear Dr. Mesa put a summary together, and we'll show that as well. Thank you so much.
I'm super excited to be here, and I'm very grateful. I appreciate the invitation from Anne and Kathleen and Ariel to be here, and I'm honored to be speaking to a group of such wonderful individuals. Like Anne said, I met her last year at the MPN and Women Conference in Chicago. I attended as a patient because, like Anne said, I was diagnosed with polycythemia vera about 9 years ago. And we hit it off, and here I am today to help maybe sort out some of the confusion about sexual health and intimacy as it pertains to MPN patients. So if you have any questions, please stop me or feel free to ask. This can be a very casual discussion. Okay, so I have nothing financial to disclose. If I talk about any particular product or procedure today, I'm not financially linked to them at all. So sexual health. Sexual health is a very important part of our identity as adults, and it really can truly directly affect our self-esteem and our happiness. And when our sexual health becomes dysfunctional, that can negatively impact our quality of life, especially as it pertains to us as cancer survivors. So there is a growing population of cancer survivors around the world. In 2016, the number of survivors was estimated to be roughly 15.5 million. And because of the aging population and the advancements in cancer treatments and early detection, that number is expected to reach roughly 26 million by the year 2040. So survivorship is important, and there's lots of issues that we as cancer patients have to deal with. And so it's important that we as physicians address these issues in a comprehensive way. I think there's this misconception that as we get older, sexual health is not as important as it was when we were younger. And that's just basically not true. There was a study in the New England Journal of Medicine in 2007, and it looked at 3,000 US adults, and their ages were 57 to 85. And they found that the majority of these adults engage in intimate relationships, and they regard sexuality as an important part of their life. And as a gynecologist, I see this over and over, that it is truly very important no matter what age, and it is something that we must address. So let's talk about it, right? If it's a problem that's affecting that many people, let's talk about it. Well, unfortunately, there's a disconnect between us physicians and patients in terms of addressing sexual health. And there was a study again in 2007 that showed that 74% of long-term cancer survivors believe that physicians should regularly ask about sexual issues. But unfortunately, that 64% of us physicians never initiate that conversation during the care. So there's a disconnect. And I think the problem lies in the fact that there can be time constraints, obviously, in a visit. And there was a study that looked at gynecologic oncologists, so oncologists that strictly take care of female cancer patients. And less than half of gynecologic oncologists take a sexual history among their new patients. And 80% of these physicians stated that the reason why was that there was insufficient time to do so. So I bring this up because it does truly take a team to provide comprehensive care. So oncologists are very busy. They have a lot of information to go over with patients and a lot of information to kind of sort out. So the sexual part of that may fall onto us gynecologists or primary care physicians. So I encourage all of you women that have an MPN to have a very close and successful working relationship with your gynecologist so that you feel comfortable enough to bring up these issues. If you don't have a gynecologist in your area, find a primary care physician who's well-versed in women's health, so that way your needs are being met. But it does truly take a collaborative effort between we as gynecologists, oncologists, primary care physicians, so that way we're not overlooking these important topics. So if we're talking about female sexual dysfunction, what exactly is it? What does that mean? Well, there's 4 components. One of them is an inhibited sexual desire or decreased libido. This is probably one of the most common symptoms that I hear as a gynecologist. Many patients a week will tell me that they just don't have a sex drive anymore, or their sex drive is significantly diminished. Inability to become aroused, delayed or absent orgasm, which is also called anorgasmia. And then the last part of this component is painful intercourse, also called dyspareunia. Painful intercourse is probably the second most common symptom that I hear among women with sexual dysfunction, especially because I take care of a lot of menopausal women, and that can be prohibitive for us in menopause if intercourse is painful. And we're going to talk about some ways to help alleviate that. So our very own Dr. Ruben Mesa was part of a study, the MPN Quality of Life International Study Group. And that study reported that 2/3 of patients, 64% of patients with MPNs have some degree of sexual dysfunction. So that's a very significant number of us that have sexual dysfunction among the MPN population. And 43% reported that their sexual dysfunction symptoms were severe. So this study included over 1,900 patients. You can see the breakdown. There were over 800 with ET, 600 and some with PV, 450-ish with MF, and 6 other. 52% of the patients in the study were 60 years of age and older, and 53% were female. And what the study looked at is that it asked those of us with an MPN to rate the symptom burden as it pertains to sexual dysfunction, rate the symptoms on a scale of 0 to 10, with 0 being no symptoms and 10 being severe. And what they found was that the overall symptom score was 3.6, which the authors in this study categorized as a moderately high symptom burden. Almost 11% rated their symptoms as being severe, 10 out of 10. That's a lot of that. 11% to me is a lot. So they broke it down further. Patients with MF had the most problematic sexuality scores, followed by those of us with PV, and lastly, those with ET. They looked at it a little bit more deeply and found that laboratory abnormalities played a role in symptom scores as well. So those patients that were transfusion dependent had the most significant impact on their sexual health, followed by those patients that were anemic, followed by those patients that were thrombocytopenic or low platelets, and then patients with a low white count were at the bottom of the list, less symptomatic. And then lastly, they looked at treatment and how does treating an MPN affect our sexual health? They found, and this graph is inverted compared to the other one, so I apologize, but patients that were steroid dependent had a greater impact on their sexual health in terms of dysfunction than patients who are on immunomodulators like thalidomide or lenalidomide. And then those patients on interferon had the least interference with their sexual health. And part of this, when I was putting this talk together, when I read this information that came out in December of 2018, talking about chronic pain in MPN patients, to me, this makes sense as why also we may be affected as it pertains to our sexual health, because more than half of patients with MPNs report feeling pain related to the diagnosis. So most commonly, 53.2% of us with an MPN report chronic abdominal pain, and 48% of us report chronic bone pain. So if we're living with chronic pain, that is a negative deterrent, obviously, as it pertains to us wanting to be sexually active, because pain affects us, obviously, in a number of ways. But if we look at factors in general, not just among MPN patients, but what factors affect us women in terms of our level of interest in sex? What are the things that affect our libido? Bladder control problems. Obviously, if we're incontinence, urinary incontinence is a common problem among females, especially in menopause. If we're incontinent during intercourse or during intimate activities, then obviously that's going to make us avoid that. Menopause and hormonal changes, we're going to talk more about that, because again, when we lose our hormones in menopause, that significantly affects our libido or our interest in sex. And unfortunately, we as MPN patients aren't always the best candidates for hormone replacement therapy, and we're going to touch on that, what we can use as alternatives. Sleep disturbance in general, so the less sleep we have, the more fatigued we are, and that affects our libido. And again, a lot of us MPN patients have pretty significant sleep disturbance. We may be up half the night with night sweats. We may not sleep well because of chronic pain. Depression or anxiety plays a role in our libido, especially because the treatment of these two entities, the medications, especially SSRIs, can negatively affect our libido. Stress in general, medications, there are lots of medications that can affect our desire to be intimate, and health concerns in general. When we're living with a chronic health disease or a chronic health problem, that wears on our mind and again, may distract us or detract our libido. And when I put this list together, I realized that most of the things on this list are particularly pertinent to those of us with an MPN. We don't sleep well. We may be depressed or anxious because we're scared about the disease that we have. Of course, we're going to be stressed. There's lots to deal with. It's an emotional burden having this disease. Most of us are on medications. Most of us with an MPN, or a lot of us with an MPN, are on medications. And obviously, having an MPN is a health concern. So we are a perfect setup as women with MPNs to have sexual dysfunction. Okay, I talked about menopause. 80% of women reported some decline in sexual desire during menopause. That's a lot. And 84% of menopausal women stated, though, that maintaining an active sex life is important. And this was a study out of 2013 British OB/GYN journal. So how do we treat it? If sexual dysfunction is so prevalent among all women, especially those of us with an MPN, how do we fix it? Well, the most important thing that I think is just providing education. And this is why I think those visits where the majority of physicians don't bring up sexual dysfunctions, because education, no matter what specialty you're in, takes time. And that's an important component of that patient-physician relationship, is how we teach our patients. So sometimes I'll just sit and talk to patients about human anatomy or the normal sexual function. I think a lot of women are under the misconception that the only, vaginal intercourse is the only way to have an orgasm. Sometimes it's just teaching patients about anatomy and that clitoral stimulation is important for orgasm. Sometimes it's talking about the normal effects of aging. What happens to our bodies when we go through menopause? What happens to our vaginas? Why do they get dry? Why does sex hurt? So sometimes it's just a matter of spending some time and explaining all of these things. I have an integrative health practice in my gynecology practice, meaning I talk to a lot of patients about lifestyle medicine. We talk about exercise. We talk about nutrition. We talk about stress reduction. And so it is important to encourage your patients to maintain an active, to be active, physically active, because exercise is important for sexual health. Limiting alcohol is important. And we talk about just having our patients schedule date nights with their partners, just setting some time aside for the two of them to be alone, to reconnect. We talk about enhancing stimulation. This can be a little touchy depending on the patient's level of comfort in talking about this, but we talk about maybe using vibrators or self-stimulation to help with some of the sexual dysfunction. Providing distraction techniques is important because sometimes it just requires playing the music that puts you in the mood, fantasizing during sexual activities. Meditation is huge, and we're going to talk about mindfulness-based therapy because meditation can help with stress reduction. We encourage non-coital behavior, so making sure that patients spend enough time with their partners. Massage, foreplay, I think unfortunately most couples kind of dive right into sex, but 10 to 15 minutes at least of foreplay, if not longer, is important, especially in our menopausal patients and patients with MPNs who may not be on hormone therapy, because that time is critical for vaginal lubrication, improving the blood flow to the genital region. Minimizing pain with intercourse. This is the big one, and this is where I spend the majority of my time with our menopausal patients, because pain is usually the #1 deterrent for intercourse. And we talk about how we do that in the next 2 slides. I'm going to go over some ways that can help. And then we use any appropriate medication that we can to help with sexual dysfunction. So I mentioned meditation. I'm a firm believer in mindfulness-based therapy because I think it truly can help with stress reduction. And I teach a lot of my patients just how to do basic mindfulness, how to breathe. In 2011, in fact, right when I was diagnosed, I was finishing a 2-year training with Dr. Andrew Weil at the University of Arizona, and he taught me a lot about mindfulness and how to teach patients how to breathe and reduce stress. So there was a review that in the literature that showed that mindfulness-based therapy works to improve sex drive in women. And it also basically because I think it's reducing our stress and it's helping us be present and in the moment, which I think is huge. So I talked about minimizing pain with intercourse. 55% of women with painful intercourse, that's called dyspareunia, rate their symptoms as moderate to severe. So when we as women have pain with intercourse, unfortunately, it can be severe and it can prevent us from, again, wanting to be sexually intimate with our partners. 64% of menopausal women will report having pain with intercourse. And that is basically because when we lose our hormones in menopause, the vagina, estrogen is very important for vaginal health. And when we don't have estrogen anymore, we have very little, our vaginas become very dry, they thin out, they crack, they burn, they itch, the worst case scenario. And so unfortunately, unless we address this issue, intercourse becomes almost impossible. So how do we fix it? How do we get rid of pain with intercourse? It can be as basic as just talking about using a very good vaginal lubricant or moisturizer. There's hundreds of these on the market. Patients have no idea which ones to get. And so I always encourage patients, if they can, to get one that's organic, because you don't want to be putting more chemicals in your body. You don't want parabens and phthalates in our body. So for water-based lubricants, Isabel Faye and Slickwood Organics are my favorite. If patients like more silicone-based lubricants, Penchant Premium makes a good one as well. I have a lot of patients who seek me out because of my integrative training, and so they want all plant-based options. And so there's a plant-based lubricant that's made from aloe vera and vitamin E, and that's called Aloe Cadabra, which is very nice. And then sometimes I just tell patients if they don't have the funds or access to some of these, I say, get a jar of inexpensive organic coconut oil. You can use it as a vaginal moisturizer. It can be a lubricant for intercourse as long as you're not allergic to coconut. You can also use vitamin E oil as well. Unfortunately, vaginal lubricants and vaginal moisturizers sometimes aren't enough, and there can still be an element of pain. So then we move into hormones. I'm not a proponent of systemic hormone replacement therapy for MPN patients because we're already at a higher risk of blood clots and strokes. So I went through menopause early surgically before I was diagnosed with my MPN, and I thought, oh, no big deal, I'll just go on hormone replacement therapy, which I did until I was diagnosed with my MPN, and then I went off my hormones, which I believe, again, it's a touchy subject, but I try to avoid hormone replacement systemically in myself and in my MPN patients. But vaginal estrogen is incredibly effective at getting rid of pain with intercourse, and it's safe for the most part in those of us with an MPN, because there's been multiple studies that show that the amount of systemic absorption of estrogen into our bloodstream when we use it vaginally is minimal. So it does not increase our risk of stroke and blood clots. So there's different forms of vaginal estrogen. You can use a cream, a tablet, a ring, and it's really just a matter of patient preference. There's also a newer product that's vaginal DHEA, which brand name Intrarosa, and that's a vaginal suppository that's made up of a hormone called DHEA. DHEA can convert to estrogen and or testosterone, and a lot of oncologists feel more comfortable with this one as well, just because, again, it's a minimal absorption of hormone into the bloodstream. So these are things as an MPN patient you can ask your gynecologist, start the discussion, so that way you can get some relief. This is a treatment that I've used in hundreds of patients. It's called Mona Lisa Touch. It's a laser therapy actually for vaginal pain and dryness. It's FDA cleared for gynecologic use. And what it does is it's a carbon dioxide laser treatment that's used vaginally. It's similar to the carbon dioxide lasers that plastic surgeons have used for years to improve collagen, elasticity, moisture of the tissues. And so they just harnessed this energy, and now we're using it vaginally. It has been a game changer for my cancer patients, especially my breast cancer patients who typically cannot even use vaginal estrogen. So it's a pretty successful treatment. It's painless. It's done in the doctor's office. It's usually a series of 3 treatments. And it basically brings the tissues back to the way they were before menopause. So it's really a nice tool to have, especially for patients who are suffering with pain. So as I leave you here today, I just want to let you know that there's multiple ways to make sex better. I believe it's truly just a matter of communicating with your doctor, communicating with your partner, communicating with yourself. Eat well, always. Exercise regularly. Get enough rest, because everything is easier and more enjoyable when we're rested. Adapt, be playful, realize that sex is not going to be the way it used to be, and that's okay. You know, sex isn't going to be the way it was when we were in our 20s and 30s, but that's okay. It may even be better. So adapt. There's always a way to make intercourse, to make better sex. So thank you.